I think we'll try and get started here just so that we can start moving along with discussions and things like that. My name is Nathaniel Brooks. I'm one of the neurosurgeons here at the University of Wisconsin, and welcome to our spine care symposium and surgical skills lab. I'm really excited to be doing this. COVID really put a big dent into our in-person conferences, and prior to COVID, we actually had a full day of symposium and also 2 days of lab, and so we're trying to get back to that slowly but surely. And the goal of today, of course, is to allow us to have a lot of exchange of ideas. You notice that we have more than just surgeons here. We have non-surgeons, we have anesthesiologists, physical medicine rehab providers, and of course everybody else in the audience, right? So we want to keep everybody in mind as we go through this. We have a great panel of speakers that are going to give us some ideas about taking care of spine patients. And I think that's really an important thing to realize, especially as a surgeon, that it's not all about surgery, even though that's what we think about 100% of the time. I'd like to thank our course sponsors. We've Medtronic, Globus, and Stryker, who have all helped facilitate this course, and we'll also be helping with some of the lab work that we do over the weekend. My only disclosure is an academic one, that I am a section chair for NASS, Minimally Invasive Procedures Committee, and so I'm somewhat biased towards that. So what's the problem? The problem is back pain is the most common pain complaint in healthcare, okay? And probably like third or fourth of the reasons that people seek out medical attention overall. So it's a huge problem. And seems to be growing. And why is that? It's very much associated with aging. Okay, so as you get older, you are going to likely have more and more aches and pains, and for whatever reason, at least in North America, back pain really tops the list, and you get more as you get older. There's also what we call a silver tsunami. The aging population, both nationally and globally, is increasing. And in the course of the last over the course of the last decade, we got to the point where we have just as many people over 65 years old as under 14 years old, and we have that percentage of the population is growing. Japan has already flipped over to where there's more old people than teenagers, and so you're going to see this worldwide. Places like China, which has done all sorts of social engineering to decrease their population, actually inadvertently caused this in a big spike. And a book that I helped edit actually is going to be published in Chinese now about taking care of spine patients in the aging population. So it is certainly becoming a bigger problem globally, and therefore will become a bigger problem for us. And the other part is that as people get older now, they refuse to quit. Okay, they used to a generation or two ago say, "Boy, I'm getting older, and I'm going to slow down." And now it's more of a, "I'm getting older, and now it's time to play." And then, of course, the body doesn't always agree with that, so their expectations are a lot higher for taking care of pain problems, getting back out there, and functioning in their hobbies and interests. But this is expensive, and it's not only expensive for the healthcare, but also for patients, right? Because they may have a pain limiting disability that doesn't allow them to work, and then also they will lose time. They lose quality time from this. So I think it's important to think about both from the healthcare and economic perspective, but also from a patient perspective. And the reason that we're all here today, spine care is becoming more and more complex. It started out pretty much like the primary care doctor and to some extent the surgeon, but as we've developed more and more interventions, it's become more and more complicated. You have figuring out what the diagnosis is, treatments that we broadly described as conservative or non-surgical, like physical therapy, how the primary care doctor actually facilitates the patient's travel through the care system, which is a huge issue. There's certainly more likelihood that they're going to order scans early than not. Unfortunately, even though we've been training everybody to not do that for decades, there still is a high propensity to start the ball rolling towards expensive care as opposed to less expensive care and less dangerous care. So what we're going to try and do today is develop a common language, and I think that's important. It's very nice that we actually have shared clinics, because that helps us do that kind of on a weekly basis, and facilitates those questions coming and going on a more routine basis. But the goal today was to try and bring up some broad topics that we could discuss to try and teach each other, what we think and how we think about patients, because I think that's really important. Things like pain generators, things like expectations of the patients and how we describe that to our patients, and then treatment options, and even as important as treatment options, but also how we describe those treatment options to our patients, because surgeon might talk to patients about injections in a very different way than the person who does injections, and vice versa. The person who does injections or pain stimulators might talk about their treatment options much differently than they would talk about surgery. And we do hear that from time to time, at least on our side. We've done everything else and everything we can do, and surgery is your only option. Okay. And then they come to us and we say surgery was never an option because we don't know what we're doing. Okay. And so this is from a study done through Larry Lenke's clinic. Larry Lenke is a deformity surgeon who is extremely busy and extremely subspecialized in spine deformity treatment. And they looked at their prevalence of greater trochanteric bursitis in their clinic, okay, which is, again, a highly selected clinic, hard to get into, very focused, and it was about 50% of their patients. And of those 50%, again, the treatments that they offer in their clinic are the most expensive, most dangerous operations you can do to somebody. Of those patients that were sent to their clinic, they treated them for their bursitis, and 50% of those patients didn't need any other treatment. They just needed an injection in their hip. And so that's a very important diagram to just point out that even in a really highly subselected patient population, you can have very basic problems that actually are actually the problem, as opposed to the very complicated things that are kind of labeled on the scans, right? So you got degenerated discs, or you have scoliosis, or you have those kinds of things, and those become your labels as a patient and can funnel you into a very dangerous operation instead of thinking about it holistically. And then the other part is what treatments are actually helpful. Okay, the expectations of the patients are to get fixed quickly and basically as simple as possible, so that they don't really like to have to be involved themselves. Typically, that is a big problem. If you say, well, the treatment is really actually what you do, not what we do, they don't like that answer. They want some sort of injection, pill, or simple surgery that's going to get them up and make them feel better. But the reality is that many times the treatment is simply exercise and movement, and has been shown to be beneficial. These papers here are a systematic review showing that in almost all cases, patients will have improved physical function and pain if they're treated just with exercise alone. And then, of course, we've got the diagnosis, the possible treatments, and then the reaction of the patients to those treatments. And that's very difficult to predict. And so that adds a whole nother layer. And we know about the biopsychosocial model of pain, and that that depending on how big the bubble is, whether it's a big biologic problem or a big social problem, can really have an effect on how the patient recovers and how they do as far as their outcomes. And if we ignore the psychologic or we ignore the social, there's many times where they don't get better, and that's partially our fault. So today's agenda, we've got 4 themes, and we're going to start out with a couple, 2 or 3 didactic lectures that just to give everybody kind of a baseline knowledge, and then discuss a couple cases so that we can all talk together about possible solutions and ideas. So I certainly want you guys to listen, of course, attentively to the didactic lectures, but think about participation as the key thing here, right? If you're not getting involved and asking questions and even giving your own opinions, it's harder to learn. And these are not the most black and white scenarios. So it's not that you can learn facts and check them off. You really have to kind of think through it and talk through it to try and learn things. So I think that's really important. Just a couple more things to talk about. We also have the surgical skills lab, which is going to be starting tomorrow from at 8 a.m. up on K4414. Is that the K4414? So K elevators to the 4th floor in the Lincoln Ramirez Operative Skills Lab. We are doing posterior exposures tomorrow, and then anterior exposures on Sunday. Unfortunately, there's only 3 cadavers. Okay, so we have a donor shortage, and so whenever you're talking to your elderly family members and they might want to be interested in donating their body, make sure to tell them that we treat their bodies very well, and we learn a lot. Okay, but so only 3 this year. There will be, of course, implant companies and surgical tool companies. It's essentially buffet style. 2 implant companies. And 2 drill companies, so you can try out those things and get some exposure there. Everybody's, of course, welcome, but we just have to balance the needs of the different learners and the folks that need to get hands-on in the cadavers the most. We'll try and prioritize that to make it work out the best. Okay, so introductions. We're going to start with Mike Sewer, who's one of our rehab doctors. This first theme is degenerative lumbar spondylolisthesis, which is actually a huge topic because it's very common. And we'll have Mike kind of give his thoughts on the non-surgical treatment of this, and then Dan Resnick, will give his thoughts on the surgical side. And you know, it's important to note, we have all been involved in a study looking at degenerative spondylolisthesis, both the SLIP-1 study and now the SLIP-2 study, trying to figure out what is the most reasonable surgical option for it, okay, which takes forever, but there's obviously more than just a surgery option. So, Mike, let's get you mic'd up.
All right. So like Dan said, Michael Sewer, I'm one of the rehab docs. I've been here for about 5 years. So I know a lot of you. If I haven't met you, at some point you'll have the mispleasure of meeting me, but all right, there we go. So teaming up with Dr. Resnick for this talk, so he'll be up here shortly. Like Dan said, you know, degenerative spondylolisthesis, it's a huge topic. When we look at this as a whole, the biggest thing on the rehab side is we want to figure out a pain generator. In the spine clinic, especially on the rehab side, that is a large part of what we do. Oftentimes, we don't have a very clear-cut diagnosis that we're looking at, and we're saying, okay, you have this one problem on the MRI, that's your problem, that's all there is to it, we fix the one thing, we're done. We have people that come in with just diffuse back pain, sometimes from radicular pain, sometimes without it. And a lot of times we go order imaging, and the spondylolisthesis is something we incidentally find. And so for a lot of our patients, that is an initial step, is the education of what does this actually mean when something's not lined up perfectly. And with all of that, we want to make sure we have the same definitions of what we're actually talking about. So most of us in this room know what a spondylolisthesis is. But we also want to make sure we are talking about the same thing, but also excluding the things we're not talking about. So not part of this discussion Our pars fractures, where you have any type of discontinuity between the anterior and posterior aspects of the vertebrae. We're purely talking about the degenerative type of spondylolisthesis. I think most of us have seen these on x-rays and on MRIs. This is one of my patients. All the way on the right side, we have the x-ray there, which is a standing view. We can actually very easily see that L5S1, but there's also a small L4-5 slip that's there. The first surgeon who saw her actually addressed the L4-5 issue. So when you look back at the MRI on the left side of the screen, that's when I ended up seeing her. She still has that L5S1 slip. And so the questions came about, is this slip a big deal? Why didn't the surgeon fix it the first time? Where's her pain actually coming from? And that ended up being something that she was perseverating on. And so when she came into our clinic, it's like, yeah, okay, that was there. They didn't fix it. Your surgery actually made things better. So maybe it didn't need to be fixed. And so there's a lot of patient education that comes into these cases initially. So pointed out these arrows here. So over time, as I got to see her, she continued to have more and more issues as far as standing, walking, starting to get some radicular pain. And so when we compare all of these findings together that I've pointed out, what we ended up concluding was that she had a degenerative spondylolisthesis that was actually moving as she went from sitting to standing. And I'll let Dr. Resnick talk a little bit more about that because that falls more into the surgical realm. But if you look at the x-ray, the amount of slip there, L5 on S1 versus the MRI, there's a little bit more on the x-ray, but also the MRI, we can see inflammation within that facet joint that indicates there may be some mobility there at the joint. Not a definitive thing when you see edema, but that is an indicator that there may be some movement there. So she ended up having that L4-5 fusion. This is the point when I ended up seeing her. So I found some x-rays from before I saw her to this is one after, and she continues to have that L5S1 slip, actually even now getting worse. And so the question that she had for me is, okay, so is this needing fixed again? So, oh, maybe, there we go. So first time she came in, it was just isolated low back pain. So the question becomes, is this truly an issue for her? Her pain diagram there on the right, aching pain across the low back, just some stabbing pain. And so the question becomes, where is this pain coming from? Most commonly, when it's isolated low back pain, you're looking at mechanical type issues, so facet joint, SI joint. You can have stenosis without neurogenic claudication, but a lot of times that is not necessarily the case. When you do start to get the stenosis, you tend to get more of a radicular type picture where they have neuropathic pain. Oftentimes they'll describe pins and needles, numbness, burning pain going down their legs. These are, again, more likely surgical once you start to get the slip with the pain going down. So I'm going to leave that to Dr. Resnick to really talk about more. But one of the big questions we get in rehab is, okay, you have all these joints, they're all right next to each other. How in the world do you figure out which one it is? And I wish I had like this golden answer I could give you to say, oh, you just do this and there it is. That's the answer. It's never that simple. You can look at common symptoms, common clinical findings, but when you break all of those down, none of them are 100% sensitive or specific. So when someone has facet-mediated pain, the common things that they're going to talk about are stiffness when they wake up. If they do too much in a day, they're going to pay for it later in the day or the next day. So they'll talk about activity pacing. Oftentimes they'll say, you know, I can do the dishes, but if I start doing dishes and vacuuming and then pick up a room, that later that day, I'm going to pay for it and I'm going to probably be down for a couple of days. Some of them will have increased pain with lumbar motion, but that's not a specific thing for facet joint. Now, one of the interesting things with facet-mediated pain and even SI joint is that you can start to get some what seems to be radicular type pain, but it's really just a common pain referral pattern. And so differentiating neuropathic pain versus referred pain can be a little bit difficult. Some of the things as far as clinic you can do to actually figure out maybe facet-mediated, maybe SI joint, is what's called Kemp's maneuver, which we call it facet loading, kind of depending on which clinic you're in, but it's essentially rotating and then going backward and try to grind those facet joints into one another. And if they have pain on that same side that you're doing that to, more likely it's facet mediated pain. You can also have them laying down, pressing on their paraspinal muscles. Again, you're pressing through muscles, fascia, you know, and the joint's actually fairly deep there. So you're not actually pressing on the joint, but this is one of the few things that actually, when you predict success with radiofrequency ablation, it's one of the few findings that is pretty strongly correlated. And what will kind of become a theme, the gold standard of actually diagnosing facet-mediated pain is blocking the pain from the joint. Now, two ways of doing this. One, this is a medial branch block. This is what we primarily would do for facet-mediated pain. So this injection, there's 3 needles on each side at L4, L5, and then S1. These are blocking the L4-5 and the L5-S1 facet joints. Now, we used to do facet joint injections quite a bit, and we still do. 2 kickers with that. One, sometimes when someone, especially if they have a degenerative spondylolisthesis, they have enough arthritis that simply getting a needle into the joint becomes incredibly difficult. So getting a good contrast pattern can be difficult, and an injection around the joint is not quite as effective as in the joint. Also, some insurances, primarily Medicare, have stopped paying for facet joint injections. They want us to do the radiofrequency. Negatives of radiofrequency, obviously it's a 3-part procedure, so there's more trips in, more needle sticks for each patient. When you denervate the medial branch, you're also denervating the multifidus muscle. So there's some debate there on how much damage you're actually doing, denervating that muscle as you're doing this long term. It is avoiding steroids, which is a nice perk. So there's definitely pros and cons of either injection type, but this is the gold standard of diagnosing facet-mediated pain. Now, just below the facet joint, very, very common overlap is SI joint. Differentiating SI joint versus facet joint on history and exam is incredibly difficult. One thing a lot of us do is actually the Fortin finger test, which doesn't have a ton of great research on it. But if you ask a patient, okay, with one finger, can you point to where your pain is? For SI joint, they will often point right at the PSIS and say it's right there. Again, you can press on different structures and see if you can isolate where the pain's coming from, but oftentimes people who have SI joint issues also have a lot of myofascial pain. So they're going to have tenderness in a lot of different areas. The same provocative maneuvers going throughout your day are often the same provocative maneuvers SI joint versus facet mediated. So again, we get into this diagnostic injection where we can inject the joint, and if you get short-term relief with the joint, that can indicate that more likely than not, the pain is coming from the actual SI joint. Now, you do need to do 2 test blocks with this. And as far as treatments of this, there's a lot of debate: steroid injection versus radiofrequency versus now fusing the joint, which some of the anesthesia or pain providers are starting to do. Neurosurgeons do that procedure as well. There's a lot of debate on the efficacy of that procedure, so I'm not really going to talk too much about that. The final thing is spinal stenosis without claudication. Now, typically not a surgical issue. Oftentimes, again, symptoms can overlap, pain with activities, but more likely pain with standing and walking. And they'll say, yeah, if I lean forward, oftentimes that helps out with pain. Now, when you lean forward, you're obviously shifting your center of gravity forward, you're tilting your pelvis. So you can have SI joint dysfunction along with stenosis. So differentiating those two can be often difficult, but oftentimes you have to treat both of them to get pain completely better. The other thing with leaning forward, especially with axial pain, the act of leaning forward, yes, it opens up the spinal canal, but a lot of people say, yeah, I lean on a shopping cart. And then my follow-up question is often, okay, when you lean on a shopping cart, are you just taking weight off of it to try to unload your spine? Or is it just by leaning forward, you're getting better? And if they have to take some of that weight off, almost giving themselves a little traction or putting a lot of weight on their arms, I tend to think maybe more facet mediated than truly spinal stenosis without the claudication. And injections aside, surgeries aside, most of the time, by the time patients get to our clinics, which is, one of the nice and not nice things about being a subspecialist, is they've oftentimes gone through some of the more conservative modalities. So I feel like I'd be remiss without saying a lot of these things are already done beforehand, but if they're not, physical therapy, medications, bracing are all options. Oftentimes I tell people the simplest option is the best option. Don't be more invasive than you have to be. As soon as I start sticking needles into things, it gets harder, more painful, more expensive, and those are all things we need to consider. As far as medications go, patients love medications because it's something you can do today. It doesn't require a lot of work, like Dr. Brooks was saying, but all medications have side effects. So you have to be cognizant of side effects, drug interactions. So if you have an elderly individual with spinal stenosis and they're walking hunched forward, you think, oh, maybe their balance isn't wonderful, but it's a neuropathic pain, giving them gabapentin, which may make them sleepy or foggy, may not be the best idea. If they get up in the middle of the night and they're foggy and they're sleepy because they've had this medication, they may trip and fall, and then you're in a worse spot than you started off with. Similarly, if it's more facet mediated, you're looking at NSAIDs, ibuprofen, things like that to help treat some mechanical type pain. If they're on blood thinners, if they're a fall risk, sometimes that risk of the medication, even though it's over the counter, may not be worth it. Bracing, there is some evidence for stenosis that it can provide relief. I think subjectively it's 50-50. For every research study I see that says it can be helpful, there's one that says it doesn't do anything. So the negative of bracing also being, if you're always wearing a brace, you may become reliant on the brace. Again, research on that is not definitive that you're going to lose muscle mass or muscle strength, but it is theoretically something that we need to at least consider when we're talking about bracing patients. It's also not going to fix the spondylolisthesis. It may help some of the symptoms as far as back pain goes, but not going to fix it, not going to cure it. So with that, Dr. Resnick, pass it off to you.
So good afternoon. I'm Dan Resnick. I'm one of the spine surgeons here. I've been here for a long time. And I've done a fair amount of work with spondylolisthesis. And I want to, Mike and I agree on pretty much everything that he said. And I actually have the exact same slides inadvertently going for it. So I'll be able to move through the beginning of this relatively quickly. The only disclosure I have is with a company called Nidus, which is really focusing on patient outcomes more than anything else, and hasn't paid anything yet. I'd like to thank the sponsors and let them know that I'm now actively looking for conflicts of interest if they have any available going forward. As Mike said, many patients with spondylolisthesis remain pain-free for many years. There does not appear to be a difference in frequency of low back pain complaints in patients with spondylolisthesis and without spondylolisthesis. So the slips are not necessarily pain generators. There is a higher incidence of spondylolisthesis in patients who come to our clinics. A lot of that is because they come to our clinics because someone found the spondylolisthesis and sent them in saying that this is something you need to do something about, which you may or may not have to. And about 10% of people who come to see a spine surgeon will have a spondylolisthesis with plus or minus with or without a pars defect. And again, that's a referral bias because the reason they're sent to us is people think that this needs to be fixed, something needs to be done about it. The longest series that I saw was a guy named Matsunaga who followed patients for 10 years with degenerative spondylolisthesis and found that there was a progressive slip in about a third of these patients. However, there was no correlation between the slip progression and symptoms. Decreased disc space height tended to protect against progression of a slip, which makes sense. And 16% of patients without neurological symptoms developed symptoms within 10 years, which means that 84% of patients who didn't have neurological symptoms didn't develop neurological symptoms over 10 years. So it tends to be slowly progressive and not necessarily progressive, not something that you need to treat just because it occurs. Those patients who had neurological symptoms, particularly claudication was a main symptom in these folks, they tended to get worse over time. And this is what we see clinically. Once people start having the claudicatory symptoms, the world starts to shrink and their symptoms tend to get worse over time. The sport studies were published back in the early 2000s. These were large, intended randomized controlled studies looking at surgical versus non-surgical treatment of spondylolisthesis. And they found that the surgical results were better in every outcome measure across 8 years. Remember, however, that this was not a patient population with patients with degenerative spondylolisthesis. This is a patient population with degenerative spondylolisthesis, which was causing neurogenic claudication or radiculopathy. So all the patients in this study had neurological complaints coming in. This really has nothing to do with the axial pain only patient. All these patients had radiculopathy or neurogenic claudication. In a post hoc analysis of the sport database in the 2010s, Pearson found that when they looked at the complaints of patients in the sports study, those patients who had back pain predominant symptoms, now they all had claudication, they all had radiculopathy, but those patients whose main complaint was low back pain did way worse than patients whose main complaints were the claudication or radiculopathy. So the theme is we're treating stenosis, we're not treating spondylolisthesis with surgery, and that's why it does well. Abdu also did a post hoc analysis of the sport data set and found there was no difference in the surgical group depending upon which operation you did. If you did a decompression alone, open or minimally invasive, if you did a fusion, instrumented or not instrumented, if you did an interbody fusion or not an interbody fusion, there was no difference in outcomes. Now, what that says, that doesn't really say a lot. The reason being is that patients were selected for different procedures based upon different factors. And so what this shows is that patients and surgeons generally have a pretty good idea of figuring out what works for them, as opposed to differences between the different procedures. From this study, the questions has come up over and over again: is fusion necessary as an adjunct to decompression in patients who have neurological symptoms, radiculopathy or neurogenic claudication related to stenosis associated with spondylolisthesis? The answer is, this is not a new question. We looked at this in the guidelines back in 2005 and in 2014, and we didn't have an answer for this question in either of those guidelines. That's not that long ago. More recently, there have been 3 randomized controlled studies since 2016 looking at this exact question, potential highest level 1 data. And there's also been 5 large, very well-controlled cohort studies looking at the same issue, to fuse or not to fuse. The European study, Peter Forst's study, was a large study looking at patients with stenosis treated with decompression or decompression plus fusion. You could have spondylolisthesis or not have spondylolisthesis in this study. In the non-spondylolisthesis group, there was no difference in outcomes, which should be, I would actually expect worse outcomes in the fusion group, because we generally don't recommend doing fusions in that group. In the spondy group, they didn't really find much of a difference between the groups either. So this clearly shows that not all patients with spondylolisthesis require fusion. There were problems with the study related to the methodology, but the patient population was very heterogeneous. They underwent a variety of different surgical techniques for fusion. Some of them weren't even fusion, they were motion preserving devices. So clearly we don't need to fuse all these patients. Well, do some patients benefit from fusion? And this is the Gogo-Wallace study done in North America, where they had a very standardized approach to this patient population. They either did a decompression alone or a decompression plus a 1950s era type fusion. And it turned out in this patient population, the patients did better if they got a fusion. They had more durable pain relief, fewer reoperations, and economically, it was cheaper to take care of them if you did the fusions as opposed to not doing the fusions, because of late reoperations in the non-fusion group. So clearly there is a patient population who does benefit from fusion surgery. Not all patients, but there definitely are some patients. This was the 3rd randomized controlled study that was done. This is different than the other 2, because the comparison group in this group was not the standard open decompression as it was in the Forst study or the Gogo-Wallace study. This was a tubular micro midline sparing decompression type thing. They aren't showing any difference between the groups, but they only had 2-year follow-up, and much longer term follow-up is going to be required for this study to be important. But hopefully they are able to do that. But again, no difference there. So not every patient requires a fusion. Some patients probably do, and the trick is trying to identify which ones do require the fusion. And this is what these are the cohort studies, same results. Interestingly, if you look at all the major cohort studies out there, this is from the American Spine Registry, from the Norwegian Spine Registry, from the LSRS registry. About 60 to 80% of patients treated with spondylolisthesis are getting fused, and 20 to 40% of patients are not being fused. So there is a sorting going out, a sorting of patients going on, but we're not exactly sure what criteria are being used for that sorting. Just a caveat on the side, this is back when I was active in the guidelines world, both with NASA and with the AANS. If you take different populations of patients and you do different things to them, and you measure the results differently, it shouldn't be surprising to expect different results. So the outcome measures in the Gogo-Wallace study and in the Forst study were different outcome measures. The patient populations were different, and they did different operations on them. So it's not 100% surprising that you would get different results there. And this is why it's very important that clinicians remain intimately involved in the development of, analysis, and interpretation of this type of evidence, because a policymaker would look at that Abdu study and say, well, look, if there's no difference in outcomes, decompression alone versus decompression and fusion, we're not going to pay for fusions. That's stupid, right? So you need to stay involved and realize that there were differences in those patient populations to be able to explain that in order to justify a lot of what we do that works. So there is a population of patients with spondylolisthesis who do benefit from fusion, but there's also a population of patients who don't need fusion, and fusion would be unnecessary and inappropriate. And how do we differentiate these groups? This is a lot of the work that we've been doing with the SLIP study, as Stan mentioned before. This is a paper that several of the authors are scattered throughout the audience here. We looked at a population of patients who underwent surgery for spondylolisthesis, and these patients all had their charts and their films reviewed by a panel of experienced spine surgeons from around the country and actually around the world. We had European as well, South American surgeons as well. And the surgeons would vote on what procedure they would do for that patient, surgery versus not surgery, fusion versus not fusion, surgery versus not surgery. And if you're going to do a fusion, what technique would you use to do the fusion? And this is a heat map. And what this shows is that your left side is when every surgeon recommended fusion. The darker it is, the more aggressive. The lighter is, the less aggressive. And you see that there's a range, both in terms of top to bottom, which are the reviewers, as well as left to right, which are the patients. So there are a group of patients where virtually nobody wanted to do a fusion, and there are groups of patients where everybody wanted to do a fusion. And there are also surgeons who always wanted to do a fusion, and surgeons who hardly ever wanted to do a fusion. And so you have both patient and surgeon related factors which are influencing the recommendation for fusion in these patient populations. Surgeon specific variables we haven't been able to figure out. I suspect it is a training bias. It could be older surgeons do less fusions. We haven't figured this one out yet. That's down the pike. Patient specific, though, we found that when we looked at the patient populations that were largely offered fusion versus largely not offered fusion, there were differences in those patient populations. And that's what we're going to talk about next. It turns out that the fusion cohort generally tended to be younger. So older patients we tried to do less surgery on, which could probably make sense. The fusion cohort had a lower health state based on EQ-5D. So these people were more miserable. Doesn't mean they were sicker, doesn't mean they had more pain because the ODIs were the same, but it means that they were more miserable. They felt that they were worse off. They had greater disability perceived than the non-fusion cohort. Probably more back pain complaints. And there are also radiographic differences. There was a greater degree of spondylolisthesis, a greater facet angle from horizontal, and there was movement on dynamic images, which each predicted a recommendation for fusion. What about spondy with back pain alone? And this is where I really feel bad for Mike because he's got to deal with these patients. There's really no good data on fusion for this. In the sports that I mentioned, those patients who had with claudication, who had back dominant symptoms, did the worst of all those groups. In general, many patients have low back pain. All of us have low back pain. Many patients have spondylolisthesis. In the absence of neurological symptoms, surgical intervention is not necessarily associated with good outcomes, and surgical intervention should only be performed in the presence of neurological symptoms, progressive deformity, or demonstrable instability. So in conclusion, patients with degenerative spondylolisthesis without neurological symptoms don't need surgery. Those with neurological symptoms tend to do better with surgery. The role of fusion remains an area of active investigation. And degenerative spondylolisthesis in the absence of neurological symptoms has a generally benign prognosis, that Matsunuka paper that I showed you before, and may or may not be the cause of chronic low back pain. And that's the patient population that is the most problematic to deal with. And I'm very glad that I have people like Mike around to help us deal with that patient population. Thank you very much.
So does anybody have any questions off the top? Otherwise, I have a question. Anybody? Residents? Any questions for these guys? We'll do cases, but just any. Okay. I'm gonna have each of you answer this while we're clicking around. Mike, why don't you start? Just kind of your general approach to. I know your talk kind of got into this, but you know, in seeing a patient with a spondylolisthesis, they typically in your clinic, Dan sent them to you, okay, because they didn't need surgery. Where do you start? What do you talk about with them? What do you do?
So first of all, I apologize for Dan's behavior for when he saw him in clinic. No, but so my clinic visits often run very similar where, you know, we take the history, we do the exam, we sit back down, and we then pull up the MRI, pull up the imaging, and we go over it. And the first thing I often say as the MRI is loading, because PACS is always slow, is, you know, one of the great things about MRIs is that they show us a lot of stuff. one of the bad things about MRIs is they show us a lot of stuff. And so that initial statement of trying to make an educational move to the patient to say, okay, not everything we see on here needs to be addressed. And that's usually that opening line. And then we start going through the MRI to discuss what's actually shown. And oftentimes we'll point out the listhesis, and I'll say, okay, this is here, but one of the nice things is it doesn't look like it's compressing any nerves. You don't have any pain down the leg. So there's no compression there. So, this is just maybe a little alignment issue, which isn't a big deal. And we just move past it. But getting the buy-in initially on not everything on an MRI needs to be fixed. And we're going to address where your pain is rather than what the MRI shows. And oftentimes, kind of throwing a joke as far as there's a lot of things I could inject on the MRI doesn't mean I need to. And patients often appreciate the fact that there is some discretion in what I see versus what we're actually trying to treat.
Yeah, I think that's important. In this era now, patients get their reports to them long before they see us. And so they see all these scary words, degenerative disc disease, spondylolisthesis, and they start looking it up on the internet. And of course, just like everything on the internet, the scariest things usually rise to the top of the search engine. And so they get the scariest thoughts in their head before they show up. And that we oftentimes have to talk them through it. Dan, what about you?
Well, I just have to smile. This morning I was on a Sirius XM radio show called The Doctors, and it was a call-in show, and it was focusing on spine surgery. And someone called in and literally was reading their MRI scan report in tears, and I'm like, this started a 20-minute digression on, ever since Congress has made us give patients radiology reports, I spent half my life talking patients off the ceiling. They all think they're going to die. It's like, I've got degenerative disc disease. Oh my God. It's like, well, it's because you're older than 18. That's what happens. So what was the question? I forgot the.
Okay, that's okay. That's exactly what I wanted to hear from you. But I think the key point is, things like degenerative disc disease is actually mostly wrinkles, right? It's wrinkles on the inside.
The line of my clinic is this is gray hair and wrinkles of the spine.
Yeah,
is all this is.
Yeah. So I think that's important. Okay, we can go on to this case, and I know Mike has to leave in a little bit, so we'll try and be careful with that timing there. This case, and the way I want you guys to answer it is surgeon side, non-surgical side, okay, and kind of defend your camps best you can, or if you want, don't just say what it seems to be obvious is it needs to be the other guy who takes care of it. So 45-year-old woman with mobile spondylolisthesis. So she describes progressive mechanical pain when she stands up, and then radiating leg pain in an L4/L5 distribution as she stands. So she really gets a dermatomal and mechanical component to her pain. This has progressed over time. And when she lies down, it gets better. Okay, all goes away. And you can see on the images that in her MRI scan, that she reduces completely. When she stands, she has about a grade 1/grade 2 spondylolisthesis. So the reason I'm asking you both your opinions on this, even though it seems like an obvious surgical one, is although this age isn't the appropriate one, that's often seen, you've got somebody who's in their 30s who has a mobile spondy, but they also want to have a baby and they want to get through this part of their life before they have surgery. So Mike, why don't you start out?
All right. So, and as rehab people, we can't pretend that we don't take care of these patients and punt them all, because if you look at the adipose tissue on the MRI, this may not be a surgical candidate. So we all have many surgical problems that are not surgical because the patient wouldn't be able to tolerate the surgery. So, yeah, it would be nice to just consult spine surgery and send it over. But if we're talking about, okay, how do we get through this if surgery really is not an option? That leaves us with a few different things, assuming they've done physical therapy to work on strengthening of the back, strengthening of the core. The debate there often comes up, okay, I did it, it's too painful. Well, what about aquatic therapy? Is there some way we can actually get you into a pool to unweight everything? A lot of times that's really, really beneficial for back pain. Then we start moving into different medications. Obviously, this is a neuropathic issue. So you're starting to look at neuropathic pain medications, gabapentin, Lyrica, Cymbalta. The incidence of depression with chronic back pain is pretty high. So a lot of times antidepressants can help with both mood and with pain. Now, obviously, it's not going to fix anything, but we're looking for, 30, maybe 50% pain relief with a medication. You can offer injections. So for someone like this, You could offer, bilateral L4-5 transforaminal epidural injections. When it's a mobile listhesis, the utility of the injections is pretty scattered. We may be able to isolate where the pain's coming from. So it could be a diagnostic injection that, yeah, we did this injection, you felt better for 8, 9, 10 hours, maybe a couple of days. But when it's mobile, the question becomes, how long does that pain relief actually last? Now, if you're just trying to get through an episode where, okay, I'm losing weight, I need to lose 30 pounds, or I need to get through this, whatever issue before I can have surgery, doing up to 3 injections per year, as long as you're getting good utility out of those injections, I think is reasonable. But when it's mobile, the question becomes, how long does it actually last? So if it's axial back pain, you can do bilateral pars defects or pars injections. Those injections tend to be pretty useful. They used to, just inject it with a little local anesthetic, and the question would be, is that then a surgical candidate for a fusion? If you injected the pars and it got better short term, could that be a surgical fix? Sometimes yes, sometimes no. I just had a patient message me yesterday who had pars injections 2 separate occasions. Both of them lasted 6 months, and she is not at a point where she wants spine surgery. So, doing 2 injections a year for someone who's delaying surgery, I don't think is a bad route to go. But we did have the discussion as far as, okay, if these injections work less and less over time, is fusion an option? But fusion for back pain for pars fractures is not the best option. So, the outcomes from that are not 100%. So a lot of people want to try the more conservative things that they can, delay surgery as long as they can.
Great, thank you. So Dan, just from your perspective, technical things, diagnostic things you might use, things like that, just to try and seal the deal.
Well, this is you tricked us. This is a pars defect here. So,
Yeah, no, that's true.
yeah.
It's not the same as your talk, but it's actually, more likely to be a surgical problem.
Yes.
So
the issue if with with claudication and radiculopathy, I don't really need any more convincing as to what's going on. You can clearly see what's going on when she stands up, she slips forward. You need to do something to prevent the dynamic compression of the thecal sac when she stands. And then we could talk about different techniques. Could you do a pars repair in this, alone? I probably couldn't, but there are people who do that. I would probably do a minimally invasive TLIF on this relatively young, healthy, low stiff woman. But the bottom line is that you can see the instability. The MRI scan matches the symptoms. And when it matches, then our results with surgery are going to be very good. And I would just do the procedure of your choice to stabilize this and maintain the decompression.
So yeah,
Right. So you have to show them the X-ray report that says that they have a mobile spondylolisthesis type thing. The pre-authorization headache now is become ridiculous. But at the same time, I've never had a case denied after a conversation. So it's a total pain in the butt. But you just stick to your guns and say, well, you didn't see the X-ray report, you didn't see it. But Greg's absolutely right. The insurance companies are looking for any excuse to delay or not pay for a surgery. So you have to be good with your documentation and need to be willing to spend a little time on the phone with a retired psychiatrist to explain the basics of spinal fusion.
I did an ortho residency, and then I went to psychiatry.
Absolutely.
Correct.
Yeah. So I think that this brings up a whole nother point, is that you can know everything about taking care of a patient and know the exact diagnosis, but the insurance company sometimes thinks it knows more than you, and you have to be able to play that game. And as a resident, it doesn't even seem like it would even be a possibility that somebody could tell you that they can or can't do this, but it actually happens all the time. They say you can go ahead and do it, but the patient has to pay for it. And once the patient sees what the money is, how much money it's going to cost, they're not happy to have it. So it does become a bit of a battle. So great. Yeah. I put that in there, because you can see how that's a very much a surgical problem, the way it's described. And then now we run into this problem, which is a 76-year-old with neurogenic claudication. You can see that it's non-mobile. I'm going to have Dan start this time, but at the same time, Mike, just think along the lines of, okay, really this patient, if this patient didn't want to have surgery, what would you do? Okay, so go ahead, Dan.
Yeah, the decision to have surgery is totally based upon the severity and duration of the symptoms that the patient has. If patients have relatively mild symptoms, there's no urgency to do any surgery. And we frequently will send patients to Mike for injections. They got a wedding coming up, or they're going to San Francisco and don't want to walk through the airport, hobble type stuff. We will frequently use injections. If this patient had significant neurogenic claudication that was not responsive to whatever Mike can do, then decompression is completely reasonable. We could discuss the possibility of fusion. I probably would not offer this patient a fusion. They have significant disc space collapse. They have little to no motion whatsoever on the flexion extension films, and the facets they're not perfect, but they don't look all that bad. So I feel fairly confident I could get a decompression without ruining the facets and would get this patient relief of their neurogenic claudication.
Great. So
that's a good point. So in the neutral film, it's relatively flat. When it flexes down, it does angle, but it's relatively flat and collapsed. If you have the steep angle there, you worry more about progression. But the facets look okay. I probably wouldn't fuse this.
So, yeah, just a couple of things. I mean, I think these are important questions from the surgical side. Is when do you need to fuse? When can you just decompress? And what kind of diagnostic tools can you use to sort that out? Flexion extension films, of course. Sometimes in these situations, I'll get CT scans to see if there's osteophytes that are bridging. That can give you a lot more comfort in making those decisions. And then facet orientation, disc height, those are all things that we talk about, think about, and nothing that we've actually been able to prove one thing or the other or group of things actually puts us in the good outcome category or not. But they are technical things that we try and use to make those decisions with patients. And then I think the other part is as Dan said, in clinic, I tell patients that when they have symptoms of neurogenic claudication, they can either do nothing, they can do conservative treatments like injections, or they can do surgery. As you go up those decision tree, it gets more dangerous, at least temporarily. And so that's basically how I describe it to them. And then of course you have to figure out along with that, remember the biopsychosocial model, and then also comorbidities. 76-year-olds rarely come without comorbidities, and it may be that they will get their lumbar stenosis taken care of, but then they have a hip, knee, or cardiac or pulmonary issue that limits their activity anyway, and so it wasn't really worthwhile. So you have to throw all those things into the mix. So now let's say that patient does have all those comorbidities, and they're seeing you.
Yeah, so this one's an interesting one. If you look at how much epidural space is available at L4 or 5, really not much that you could stick a needle into. That's borderline, critical stenosis, where if you try to stick a needle into that and even put in a couple tenths of an ml of contrast, they're going to get pretty severe pain. So you can't really inject at that level. Looking above where there may be some epidural space, if you look at the flow when you inject medication, so for our typical injections, it's 3 mLs of total fluid. So 2 mLs of local anesthetic, 1 of steroid. That's going to flow up 1 level and down about 0.4. And so getting caudal spread from an epidural injection really is not a lot. So you may have more room above, but you're not going to affect that level where the narrowing actually is. So then, okay, can we inject below? Injecting L5S1 tends to be a little bit more difficult anyway, because not as much epidural space there. And on this one, it really doesn't look like there's going to be much there either. So for an injection standpoint, you're kind of left with 2 options of either a caudal epidural injection, which is a higher volume, kind of pushing the medication up, and it's very nonspecific. So if that helps, you don't really know which level it's helping. That's going to go up to about L3. Or maybe even L2. The other approach is bilateral transforaminal injections, which then you start having the difficulty of, with as much arthritis as there and how narrow it is, getting a needle with actually satisfactory epidural flow. So if you're looking at an AP view, getting the flow medial to the pedicle gets pretty difficult. So on this one, I mean, I would probably opt for caudal epidural injection for just safety and ease of doing the injection. A transforaminal, when it's that tight, can be awfully painful as well, as being the technically difficult. But again, this is going to be one of those, you're assuming you're treating the neurogenic claudication and not necessarily back pain. Someone with this much narrowing is probably going to have some mechanical back pain associated with it. So again, you're having the discussion of, okay, this injection may help some of the pain, not all the pain. Let me know what's better, what's not, because there's other targets to go after.
I think that also brings up another interesting point that Dr. Leonard and I get into a lot is surgeons typically think anatomically when they order injections, that wherever the most stenosis is, that's where they order the injection to be done. And I know, at least in talking with Dr. Leonard, it seems as if you guys are working more along what's going to be the most therapeutic option for treatment from a pain perspective. And so that's why you often see us order the L4-5, either transforaminal or midline injection, even though it makes the least amount of sense or from a safety perspective. So I think that's important to know. So just for you guys, they may actually contact you and change it. You know, if it's going to be for therapeutic purposes rather than a diagnostic workup, you may change it to the L5S1 level or a bilateral transforaminal or something like that. So important to know. Okay, great. Well, guys, thank you very much. I know Mike has to get to do some injections, and Dan will be around for a little bit longer until he flies out of town. So good. All right. Thank you very much. Yeah. Okay. Our next theme is going to be cervical spondylosis, which also is endemic and related to aging. We're gonna have two speakers. Michelle Poliak-Tunis and then Brad Schmidt. Michelle's going to talk about the non-surgical treatment of this. And so thank you very much. Appreciate it.
All right. Well, hi, everybody. I'm Michelle Poliak-Tunis. I am one of the PM&R pain doctors. I'm also the PM&R program director. And I'm here to talk about cervical spondylosis, obviously the non-surgical side of things. A lot of the things I'm going to talk about, Michael Sewer, who already left, mentioned, because there is an overlap, obviously, between lumbar and cervical treatment from our side of things. So just bear with me, because if you already heard it, I'm sorry. And we are going to do cases, but I kind of put this in there anyway. So we get this a lot. Patients come in, 60-year-old cervicalgia, cervical stenosis, no myelopathy. So what do we do in our PM&R pain clinic or spine clinic? The biggest thing I would say is starting with a good history and physical examination. You're going to learn most about the patient from a history and physical examination. Kind of like with lumbar spine, what they were discussing earlier. A lot of times patients come to my clinic and I'll say, what brings you to clinic? And they'll say, oh, I have a disc herniation between C4 and C5. And I'll say, oh, okay. Well, why, how do you know that? Oh, I got an MRI. Okay, well, why did you get the MRI? Oh, because I was having neck pain. Okay, so again, the more you ask the patients to tell you a good history, the more you're going to learn about the pathology. And as you guys all know, MRIs can have ugly things when that may not be the cause of their problems at all. So what do I care about, or what we should all care about? You know, when someone comes in with neck pain, is it axial? Is it radicular? You know, what have they tried for their pain in the past? Has this happened before? How long have they had this pain? Do they have any associated weakness, any paresthesias, any loss of balance? Anything else we should be concerned about? On physical, what are we most worried about? You know, we want to watch them walk. We want to do a full neurological exam, including cervical range of motion, strengthening sensation, checking reflexes, checking Hoffman's, cervical spurling, you know, to see, does it radiate down their arm, cervical facet loading, and then really also include the shoulder, because a lot of times neck can actually be shoulder. So you do your history, you do your physical, patients say, okay, what medications can you give me? Because I just need something to fix me right now. You know, we'll try NSAIDs temporarily, over-the-counter acetaminophen. If they're having myofascial complaints, we can try muscle relaxants temporarily. Anyone who's having radicular symptoms, could we try neuropathic medications such as the anti-epileptics like gabapentin, Lyrica, the SNRIs like Cymbalta, tricyclic antidepressants. Is there a role for steroids? You know, if they're having this acute pain going down their arm and you think it's a disc herniation, should we try like a Medrol dose back temporarily? And opiates, almost never. please don't give them opiates for chronic neck pain. Please. We'll send them to physical therapy. What's the point of physical therapy, right? To help them with their pain, help them with their function, improvement, and quality of life. So we help them. Well, the physical therapists work on range of motion, stretching, strengthening. They could try modalities like a TENS unit, dry needling. And the biggest thing with physical therapy is for them to develop a home exercise program. Because I hear this all the time, physical therapy didn't help. And then I'll look and they went twice. Well, yeah, physical therapy is not going to help twice when you don't do any of the exercises at home. So I always put in my order to physical therapy HEP so that I know that at least from my end, I am telling the physical therapist, please come up with a strategy for the patient to do this stuff at home, or else we all know it's not going to work. And then in the pain clinic, we have our own health psychologist, and they also work at a spine clinic. And this is for the patients that have had chronic pain and to really kind of help them with coping strategies for chronic pain. You have to have buy-in from the patient, right? Because when they hear that, they immediately say, you think this is my head? And I have to tell them, no. I tell them the way we physically feel affects our mind, and our mind affects the way we physically feel. And I literally go, and I can't disconnect the two. So this is where sometimes they'll start realizing that, yeah, their chronic neck pain, which is what we're talking about, is now affecting their quality of life and their ADLs. So maybe pain psychology could be helpful for them. Now you've done all that and you've examined them and you think, hey, it might be some myofascial neck pain. So for this, we can do trigger points in clinic. There have been multiple studies demonstrating that you can have a trigger point in one area and have a referral pattern elsewhere. So even though the trigger point may be in the upper trap, it can radiate up the neck, up to the temporalis area. So we do a really good physical exam and see for these trigger point injections, we do these right in clinic. We use a little bit of lidocaine, and then we just needle the muscle to hopefully decrease, to then release the taut band and then improve pain relief right then and there. We don't use, typically steroids are not used. So usually just a local anesthetic is what's used for these. I go where it's most painful. And then what you'll do is you'll needle and then you'll feel twitches, and the patient, I'll tell the patient, hey, you might feel something that's normal. Because again, any unknown, they get scared and think that they're dying. And you'll feel a twitch and then the muscle will release. And the lidocaine is just there to help with pain. That's not what's actually doing the work. It's the actual needling part. So what if they have axial neck pain and you think it's facetogenic? So Michael was talking about referral pain patterns from lumbar facets. Same thing goes with cervical and thoracic. You'll get referral patterns of pain from these cervical facet areas. With these, like Michael was alluding to before, we tend to do medial branch blocks when patients have, chronic axial pain. You've facet loaded them, it refers their pain exactly kind of the area that you may think. And we do 2 diagnostic tests. One, and number one, because studies have shown that you have a higher chance of effectively doing a radio frequency, but also insurance requires us to do 2. So that's another reason why we're doing 2. And then go to radio frequency ablation. This is very busy. Don't read all this. I just wanted to put something in there. Basically, saying this was a consensus group when whether or not we should be doing cervical facet injections versus medial branch blocks and radio frequency. And basically, they found that the radio frequency could provide benefit to well-selected individuals, with medial branch blocks being more predictive than intra-articular injections. Obviously, more stringent selection criteria are likely to improve denervation outcomes. Pretty obvious, but at the expense of false negatives with lower overall success rate. And clinical trials should be tailored based on objectives, and selection criteria for some may be more stringent than what is ideal in clinical practice. So this is kind of what it will look like when we do the medial branch blocks. The picture on the left is from a lateral view. Obviously, picture on the right is an AP view. And this is kind of the targets of where we're going. The big thing when we do these medial branch blocks is we put a very small volume of anesthetic in. Again, no steroid whatsoever. And we ask the patients what their pain level was prior to, and then they keep track of their pain. Throughout that day, they get sent home with the paperwork on how to do that. They call us the next day. If they receive benefit, and we don't tell them how much because we don't want false positives, then we will schedule them to do the second block and then possible radio frequency ablation. And again, we assume, or studies have demonstrated that the radio frequency can help patients for up to 13 months on average, which is fantastic for these patients that have a chronic neck pain. Now, what if they have radicular pain, right? So I've talked about myofascial, I've talked about axial. What if they have the pain going down their arm and you're, again, you do your history, you do your physical, they've tried the medications, they've been on gabapentin forever, and I'm not sending them to you guys yet. We can try cervical epidural steroid injection. The picture on the left is an interlaminar, picture on the right is a transforaminal. For interlaminars, we usually go at C7T1 because it's the largest posterior to anterior distance between the ligament flavum and the spinal cord. And so that's kind of why we target C7T1. If C7T1 has no space, we'll go to T1, T2. Obviously, from a surgical planning perspective, and for you guys to know, is this the level I should be targeting when you do surgery? Transforaminals are definitely going to be more efficacious for you guys. That being said, it's a lot riskier when it comes to procedures for us, given the fact, anatomically where we're going to be sticking that needle. The other piece is whether or not, what kind of steroids were used for these procedures. So many, many years ago, people were using all kinds of steroids for epidural steroid injections. And what they realized was that they were having higher complications with using particulate steroids. So we've now changed over to pretty much, I don't say we, most people have changed over to using just dexamethasone as a non-particulate steroid to decrease the risk of adverse events from these procedures. Yeah. Yeah. So what happens was they were clumping in the venous structures and could potentially increase risk of ischemia. So that's where, yeah. So now there were studies demonstrating that particulate actually may help pain relief longer, but risk versus benefit, we just, as a whole. Now, that being said, there's no real good gold standards for 90% of the procedures that we do. So people can still do whatever they want, right? But when you pull up triamcinolone on the vial and it says not to be used in the epidural space, probably shouldn't be using it in the epidural space like many people do. So. And it was short and sweet, but again, big thing is just really doing really good history and physical. We can help you guys a lot, but it'd be nice to kind of have this there for them. And knowing that a lot of the things that, again, you'll hear this all for lumbar, I'm sure, and like Michael already talked about, but there are plenty of injections we can do, but it's just for the right patient at the right time.
For those that don't know, I'm Brad Schmitz. I'm the current spine fellow. I did my residency training here as well. I just found out that the Chiefs had a bet that I would or would not mention that I was going to be staying on as faculty next year. So I definitely won't be mentioning that just to spite them. I also envy Dr. Resnick a little bit. He had 10 minutes to talk about a very specific grade 1 degen spondy. Dr. Brooks called me up and said, Brad, you have 10 minutes to talk about all the evidence for all the surgeries we do on the cervical degeneration. Cool. Thanks, Dr. Brooks. So we'll try to fly through some things today. So no disclosures for me because I'm just a fellow. So what is cervical spondylosis? So it's the progressive deterioration of the osteocartilaginous components of the cervical spine. This can result in neck pain, radiculopathy, and myelopathy. Obviously, it's from a surgical standpoint, we're mostly worried about the radiculopathy and myelopathy component of that. So I'm not going to go over these cases specifically, but cervical spondylosis can come in many shapes and forms, right? So here you have stenosis from degeneration throughout. Here you have really no midline stenosis, but you can see on the left side some very severe foraminal stenosis. Here you have sort of a congenital abnormality with also some degeneration likely accelerated because of that. And here you have whole other animal, right, where you get degeneration that actually isn't even affecting the neurologic structures, but actually the airway and the swallowing. So you get all sorts of varying forms of degeneration with cervical spondylosis. So kind of going through some of these surgeries though, so I figured I'd start off with arguably maybe some of the more simpler ones. So posterior cervical foraminotomy. A lot of studies have shown the effectiveness of posterior cervical foraminotomy can result in 90-96% improvement of radiculopathy. This is one of the major studies. It was retrospective, but it was 162 cases with 5-year follow-up. they found that 95% resolution of radiculopathy over time with no statistically significant change in segmental kyphosis. And we'll talk a little bit more about that. It was published in JNS. A lot of studies too nowadays are looking into open versus MIS versus endoscopic foraminotomies. And so here in the Journal of Spine Surgery was a nice meta-analysis looking at some of these comparison studies. And what you'll see kind of across the board that I've highlighted is that the open foraminotomies typically a little bit longer, typically a little bit more blood loss, and typically longer hospital stay. Whereas both the minimally invasive and the endoscopic result in less than that, but overall the outcomes are generally the same between the cohorts. And oh, perfect, that also translated well. So quickly though, really the degeneration that happens at the adjacent segments does not particularly accelerate compared to ACDFs or other approaches. That was it's still about 2% per year, and that was seen in the Spine Journal published by that group. And then as in residency and from our faculty, we often hear about you try not to take more than 50% of the facet joint because that results in instability there. That was we get that number from a nice paper by Zadeblik here. It was a biomechanics study where he analyzed that and found that 50% sort of that cutoff. So obviously you want to take enough of that medial facet in order to get a decompression and get to the nerve root, but you don't want to take too much and destabilize. So another surgery that we do are cervical laminectomies with or without fusion. And obviously Dr. Resnick left, but I was going to make a joke and say I wish too bad someone wouldn't publish guidelines on this, and so the joke is that clearly Resnick and a group of people did publish guidelines on, oh hey, they just walked back in, there it is. Right, so guidelines have been published on this and showed that laminectomy with or without fusion does do a satisfactory job of treating patients with CSM is cervical spondylotic myelopathy and with OPLL. They also found in the guidelines that laminoplasty and laminectomy with fusion both offer good improvement in neurologic outcomes, but the one difference kind of between those is that in contrast to laminectomy and fusion is really not associated with late deformity. So when you do laminectomize someone without fusing them, right, you do run a risk of progressive kyphosis over time. And so studies have shown that rate may vary between 12 to 38% as you go along. This is a study that was done also in JNS that found that over time, about 47% of patients ultimately had progressive kyphotic deformity on post-cervical laminectomy. But remember, most, if not all of these actually did not cause neurologic deterioration. So just because you see something on the graded radiographs doesn't mean that you actually have to treat it. So important to remember. This basically said the same thing. So cervical laminoplasty, right? Another surgery we do. So there's been a lot of talk. A lot of the initial cervical laminoplasty data was out of Japan. That's because there's a high prevalence of OPLL. And so they obviously want to develop another surgery to help treat that wouldn't result in a lot of CSF leak rates from a ventral approach. But there's been a lot of data that show that laminoplasty can be a very effective treatment for cervical myelopathy. And so this is a nice review paper in the Spine Journal. I put this up more for the residents because it talks about just the general sort of description of techniques, outcomes, and shows that obviously the laminoplasty is effective at treating patients with progressive myelopathy in the cervical spine, and that it's not inferior to laminectomy and fusion. This was a nice paper also in JNS published by John Ratliff that talks about again no real change in outcomes between laminoplasty and laminectomy, but they did also mention the one thing I want to bring up, right? Laminoplasty is sort of that one procedure I feel like where it can happen with any of the cervical surgeries we do, but we talk about that CE5 and their root palsy, and they quote that at 8%, and that was, like I said, described in this paper as well. And so there have been some randomized studies to look at whether laminoplasty versus laminectomy and fusion whether one's more effective than the other. Now, this was a study actually published in the Red Journal. Granted, it's a relatively small study. They only had randomized 7 to the lamina fusion and 9 to the laminoplasty group, but it did show that that obviously both cohorts did very well post-operatively. But the range of motion, and obviously, right, this is sort of the whole point of doing the laminoplasty versus the laminectomy infusion. Laminoplasty hopefully will preserve your motion going forward. And they found that the range of motion between C2 and C7 was reduced by about 75% in the fusion group versus about 20% in the laminoplasty group. They also did find that the lamina fusion group had on average a larger area of canal opening versus laminoplasty. And I think that makes sense for a few reasons. One, when you're doing your laminectomy infusion, you do the lamina, you're obviously removing all that bone. And I think inherently when you're going to fuse, you may be more willing to take a little bit more of that medial facet off and get a little bit more decompression as well. So again, that sort of makes sense. ACDF, another obviously very common surgery that we do. There's been a lot of data obviously on ACDFs. It's hard to know where even to start, but this was just a nice study published in Spine. It was a 10-year follow-up, and that's why I kind of wanted to show it. That shows that over time, that neck pain and disability outcomes over time, number one, improve, but then are sustained with ACDF. And so ACDF is sort of tried and true surgery, and patients do very well with it. The bottom chart here is showing the rate of adjacent segment disease. And you can see, and I'll talk about that paper here in a second where they specifically talk about that, but you can see that chart trend follows the number we typically quote is between 2 to 3. I think 2.9% is actually what was specifically mentioned in the paper I'll talk about. But you can see that this trend, if you chart basically every year, right, it goes up by about 2 or 3%. So it follows that trend as well. So here you go, right? So another number just for the residents that we always throw around is right that a rate of adjacent segment disease when you do an ACDF is about 2.9%. And where did that come from? Well, it came from this paper, Journal of Bone and Joint Surgery, where again they looked at patients for about 10 years, and you can see that their average incidence of adjacent segment disease was about 2.9%. And what's interesting too, and it inherently makes sense, if you look at the prevalence of new disease, it correlates specifically with the areas of the spine that have the most motion, right? And so that, again, that makes sense, right? The areas that are going to be have that baseline motion are going to be more are going to be higher risk to obviously develop that adjacent level degeneration. Utilizing hardware, obviously a little bit of this you have to be cautious with is pushed by industry, right, too. But there have been studies that show that utilization of plates and screws in ACDFs does increase fusion rate and decrease subsidence. This was a meta-analysis done also in the Spine Journal that looked at that. The top odds ratio chart is the rate of fusion. So you see the rate of fusion, the overall, and this is the blue diamond at the sort of the bottom of that chart. Rate of fusion was slightly increased when you use the plate and screws. Subsidence was slightly decreased with plates and screws. Dysphagia, there was actually no difference between the groups. So that's also important to know. Now, a lot of that obviously depends on the type of plate you're using, how well the plate goes in. Did you do a good job in surgery taking off those osteophytes, right? Because if you leave that plate up and angled, right, they're going to have dysphagia. So, and then I just included these because I thought this was interesting, but the neck disability index and visual analog scale, NDI didn't change between plate and no plate, but interesting, the visual analog scale did. And so if you had a plate, technically, apparently their pain was a little bit better subjectively. I don't know if that's because maybe they saw their x-rays in clinic and so they thought, hey, I got this hardware and suddenly I feel better. Who knows? I don't know. I just thought that was interesting enough to put up. Arthroplasty is the last thing I'm going to get into. Sorry, I know this was a long thing. There's been a lot of studies that talk about arthroplasty. Now you have to be also cautious with these because a lot of these are industry sponsored based on that specific arthroplasty. But one of the main ones that we talk about here for the residents, right, is with the Prestige, which is the Medtronic based arthroplasty. This was done with Dr. Mumanemni and Zadeblik here. They found that at 2 years, arthroplasty with this Prestige disc specifically did really well. Patients had good neurologic improvement, had preserved motion, and it did reduce the rate of secondary surgery. You can see some of that data here I included. The rate of secondary surgery is sort of that the middle chart. I'm pointing to it like you can see where my finger is. But you can see that the control group, which was the ACDF, had 9 cases and 12 levels of adjacent segment disease, whereas the investigation, which was the arthroplasty, only had 3. These are the other two. I won't go hammer them home, but these are two other randomized studies for the varying other arthroplasty discs. One the Bryan disc, and one the Pro disc C. They have similar outcomes, as you would hope, probably not be surprised. And the last thing I want to talk about, which I thought was interesting, is you know, the whole point of arthroplasty is try to preserve motion. So if you can do things to help try to preserve that, it's advantageous. And so there are studies that have looked into if you do an arthroplasty, if you don't put them in the brace, that's actually potentially more advantageous, because you encourage them to keep that motion up and help prevent heterotopic bone formation. And there's mixed data about whether actually, you know, normally in ACDFs, we tell patients not to use NSAIDs, but there's actually some, again, mixed, I should say, data about encouraging patients to have NSAID use in the first couple of weeks after an arthroplasty, again, may potentially benefit them from forming that bone. So that was a whirlwind, but there you go. That's all you need to know about the data for cervical spondylosis. Thanks.
Okay. Does anybody have questions for these guys while I'm loading? Okay, great. So, oh yeah, we'll get a mic for you guys up on the front there. We'll start with this case. Okay, so this is a 60-year-old patient with neck pain, cervical stenosis, but no myelopathy, meaning no clinical or exam findings that are concerning for myelopathy. And it may not project that well on the screen. There is a little bit of cord signal there. So what I'm going to start with as a question is for Michelle. How comfortable are you guys taking care of patients with this much stenosis and no symptoms?
I think the no symptoms is key.
Yeah.
And I think that every time we ask the patient, you know, again, history and physical, any slight changes, we get a little anxious. And then I send Dan a message, hey, do you mind seeing this patient sooner rather than later? But if they don't have symptoms, I think that for the most part, these are the patients we see in our pain clinic and our spine clinic. And going back to what I was talking about before is what are their, you know, what are they experiencing? You know, are they having, you know, neck pain that you can feel and is palpable and it's myofascial? Can we do something? Is it axial? So again, going back to what are they experiencing, and then how to target it. But as long as they're not symptomatic from that.
Right. So, and thoughts from anybody else in the crowd? There is some cord signal change here from the surgery side. What would you watch this person or just treat them? You.
I think the patient needs a better exam. If they're congested stenotic, you can pick that up on the plate.
Yep.
Spinal line, such as back, sex, and you've got a signal change in your work. They have to have some either sign or symptom.
So yeah. So very low threshold to watch on that end. And I know this is very much like a surgical case. It's kind of like the other one. We would really push you guys to think surgery would be the thing. The only reason that you wouldn't do surgery on this is literally the patient refuses to do surgery. Yeah, or they have comorbidities that are dangerous in some way. So, Brad, thoughts on surgery for this?
Yeah, I agree. You know,
Or other studies or anything? Yeah.
Yeah.
Your
You know,
workup.
I agree completely. You know, I think waiting on this would make me extremely nervous, right? They have what looks like, I think on the X-ray looks like there's a pretty significant disc herniation there with T2 signal change. Unless there was, like Dr. Trost and Dr. Brooks were alluding to, a very specific reason not to do surgery. I think that's probably indicated in this patient. Approach, I think, is you know, there's a lot that goes into that. For me, I think the tried and true for this would probably be an ACDF, right? It's pretty well tolerated. People do pretty well with it, as you know, clearly on the presentation I just gave. But I think that's a reasonable indication, especially given, you know, the things to think about, right? So do you go front and back? Do you fuse? You don't fuse? Right? These are all the things that are running through your head when you're doing this. And I think the thing that sort of pushed me towards ACDF is the age, the disc space, and then the fact that there's that big ventral disc herniation there. As far as other studies, At this point, I mean, I don't know if there's much else I would honestly need. I mean, they have upright x-rays, the MRI is pretty convincing. I agree with Dr. Trost. I'd get a more thorough exam just to make sure that I would expect with that signal change that there'd be something subtle there. But
Yeah, not, Dan, go ahead.
yeah, to see, because that disc, I agree, that does look a little strange. There could be a calcified component of that disc. I agree that could be, but yeah.
Yeah, so I was just gonna say, I mean, it's not meant to be a gotcha kind of scenario, but I typically will get, if there's very large ventral disc herniations and they have a bit more of a confluent pattern, I will typically end up getting CT just to make sure we're not dealing with too much calcification or ossified posterior longitudinal ligament, just because of technical challenges of dealing with that. And
The other problem about really asymptomatic cervical stenosis, if you look at statistics, the risk of doing surgery is greater than the risk of maybe the look of the comment. I've done this now 30 some odd years. I've never had a patient that comes in and says, catastrophically deteriorated. Clearly an asymptomatic. If they're absolutely asymptomatic, catastrophic deterioration is reported.
yeah, that's
Right. Right.
yeah, it's like they would have injured their spinal cord with or without the yeah.
Yeah. Right.
Mhm. Yeah. I count that as kind of like the warning signs, like the warning shots going off. Like if they have radiculopathy, but they have stenosis, I'd treat them both. And yeah. Mhm. Yeah. So I think those are all good things. So question for the crowd, how do you guys follow asymptomatic patients? What do you do for, do you have them in clinic every year? Do you give them your phone number? Yeah. Yeah, you have it on your phone. It's a reminder to call. Yeah. Yeah. Yeah, it is. It's the right thing to do, but also anxiety provoking. And then every year you have to kind of like remember what they, hopefully your notes translate well enough. You can remember what they were like the year before and all that kind of stuff.
But you're hoping that you follow them in a year and all of a sudden they're having symptoms at that time. I mean, this is all going to be symptom driven anyway.
Yeah. So I think, right. So I think that's the other version of it, like where do you say, okay, if we've made the decision not to do surgery, then they're going to come back when they have symptoms, or do you every year kind of do an exam, make sure they're not missing their subtle hyperreflexia or ataxia or those kinds of things. So kind of an interesting challenge. No good answer for that. Okay, so Brad did surgery, but the patient still has neck pain.
I've never seen that.
Yeah, right. So
That would never happen.
So that's the thing. That's the thing about this, is that this is the perfect patient where they basically you're going to recommend like a surgical treatment, but it's actually not going to deal with their problem, and then you end up with a patient that has an understanding that you saved their spinal cord somehow, but not exactly understanding why, and still has the same symptoms or worse new symptoms that they have to deal with. So what?
Yeah, and I keep repeating myself, but just doing a physical examination, right? Seeing where they hurt and why do they hurt. A lot of times these patients have myofascial pain after surgery, and you go in, and what's nice about doing trigger points is we do them in clinic. We don't have to go to the surgery center, and we just there, as long as they're not any kind of antibiotics for whatever reason, we can just do it in clinic. And a lot of the patients do really well. Sometimes we do repeat, 6 to 8 weeks later, but they are very happy when they leave clinic.
So myofascial pain, and I think you showed some great diagrams on that. It's amazing how much overlap in like dermatomes and neurologic things, because patients will come in and they'll be like, doc, I get pain that goes from here down into my arm. I looked on the internet and it says that is a nerve pinch problem. and you need to do surgery on me, but when you examine them and even if you do like trigger points or palpate the most painful spot, sometimes it will reproduce that pain. And at least that's what I use to try to determine whether it's a myofascial thing or not.
Yeah, I agree with you. I think there has to be buy-in from the patient too, because I will be in spine clinic on Monday afternoons and patients will assume that I'm a spine surgeon because they will refer to the surgeons and the surgeon said, no, we're not going to see you, but no one told the patient. So I have to then do that.
If you go through that piece, yeah.
And a lot of times it is that myofascial pain. I think to myself, oh my God, if they ended up in your clinic.
Now, I gotta admit that it does happen to us, but patients are usually happier when they hear they don't need the surgery. Okay, so
I keep saying same things that physical exam, right? Touch the patient, see what's going on. Don't just look at their MRI and just talk to them for 5 minutes. Really, absolutely see what's happening.
And looking at cases of myelopathy, you have to know what questions to ask.
Yep.
It's functional things that you have something walking in the dark. Or those are key questions. They answer the clinic. If you walk that they're not oftentimes they operate on people like this asymptomatic but have things like this. I didn't really know that I was having a problem. Now I took it better.
Yeah.
In my very extensive experience thus far, I found handwriting decrease is actually something too. People come in and won't acknowledge it, but will realize that yes, my hand, I'm writing checks and my handwriting has gotten significantly worse over time too. So
They would never be able to pick up that on me. It would be. It looks like I have myelopathy. I don't know what my deal is. Don't check. Okay.
I'll do your surgery. It's fine.
Okay, so good. That was great. So next case, this patient does have myelopathy. Okay, so we'll start with Brad.
Yeah, so 45-year-old, you can see, obviously they have a multi-level degeneration on the MRI with central stenosis basically from C3, 4, roughly, arguably all the way down to 6, 7. I'm not really counting. I'm just looking, but it's the whole cervical segment. The other thing you can really appreciate on the CT is that they have OPOL. So obviously doing things from the front would be risky, as we've already talked about. And so the question down to this is, if they do have myelopathy, I think this, this person is 45. You obviously the main thing in clinic is you want to tell them, right? Surgery is the main goal. We said this a million times, right? Is not really to make them better, but is to prevent them from getting worse. Now, as I talked about in some of that data, whether you caught it or not, because it went so fast, but some people do get better. Okay. And in fact, a lot of people do to an extent, but the goal of surgery is to prevent the myelopathy from getting worse, obviously. And so then the question becomes, what do you do? There's a little bit of obviously loss of lordosis in the cervical spine and a little bit of a kyphotic deformity. I think erring on the side probably of laminectomy infusion would probably be the best option here. Given the extent, 3, 4, 5, 6, 7, if you needed to decompress all the way down to 7, which it looks like you probably have to, you would potentially then obviously want to consider crossing the cervical thoracic junctions. Then you'd be looking at maybe a C3 to T2 C3 to T2 fusion with 3 to 6 or 7 lami. Now, if you weren't going to cross the C7 junction, obviously you can maybe stop at 6. But I think on this one, especially with the amount of generational PLL, I think C3 to T2, something like that would be reasonable. Yeah. It's sort of that. Yeah. It's sort of that what they call it, the mixed or whatever the.
Yeah, I don't know. What is the issue with that spacing between the body and that calcification?
Is that calcification the disc? Is it?
No, that's the
another
dura. It's
resident.
the
Let's have
dura.
a
It's the
resident.
double. The double. You were talking about that double size. It's the dura. It's calcified. Yeah.
So.
Well, yeah.
Yeah, so I think that's important for the residents to know that is actually the dura, not the disc, that's calcified. And so you get in there, try to decompress and on the front side anteriorly, and you'll end up just carving out dura, and then you can't sew calcium. So it's very hard to fix all those problems once you start them. So, so Brad, your thoughts are
you've kind of taken yourself down the path of they have myelopathy, but now you're going to create a big long fusion. Just for devil's advocate, what about the balance of their spine overall? You know, like what do we think?
Yeah, I mean, it's hard because we're only seeing their,
Right, you don't see
yeah.
the whole thing, but let's say, what other studies would you want to do, or what would you
you
decide?
could get, you know, obviously flexion extension, you could get then Scully films, to see the overall alignment of their spine, but.
Because would you be concerned if they had a positive sagittal balance in their cervical spine, that you would then,
Yeah,
yeah,
that
so then you'd make that permanent, and inflexible at the same time. So, and then back to Michelle's clinic. None, yeah.
So,
Right, so any other thoughts about the surgical plan? You know, are there, I mean, it's a certainly very reasonable option, but is it,
This case is kind of it's a hard to make a good recommendation on because he's kind of over ventral mass.
correct?
So,
Yeah.
Get enough spot mass. Like, you could get some correction of the curve. Give him some of those to allow the posterior procedure to be more effective. That's a huge undertaking. Actually, with fine facetectomy, thorough facetectomy to release the posterior.
Yeah.
And just suggest the skectomies and probably slowly at least get it straight.
So you're thinking more of like an anterior approach to release and create kind of more of an anterior.
Not easy. I think you can get at least eventually down.
So more of a structural thing. Basically, you're putting implants anteriorly, getting a little bit more lordosis, then you're going to flip over and do the rest. And
This to start with.
Yeah.
You need to do it. It's a fixed deformity. Go in the back and these, this complete unroofing of the roof because it'll still leave you bone to fuse, and then they go in the front to do releases, which means the skectomies, spacer, how spacers in the crack that will the deformity operates a giant number.
yeah, I mean, that's the whole reason I'm bringing this up is the patient just has myelopathy. Is there another option of just doing a laminoplasty and following them and then fixing the deformity if it worsens? You know, I mean, of course there's an option, but would people do that? Yeah. How, Mhm. Yeah.
Yeah, I would give them some room for it.
All right.
yeah, it might be, I mean, again, it might.
Paul.
Like, how long, I guess, would you give him before you're like, your A9 developer is getting the first one, maybe we could use it. If he's getting worse, he probably after. Yeah, I didn't know like how long. We've already seen, everybody says the stated goal is to keep it the same, but I don't think that the vast majority of my myelopathy patients notice significant improvement in the depression. Know that they're all the folks saying, but that's kind of
That's a CYA comment. That's a cover CYA way of saying it. Yeah. Yeah.
Yeah, stress. You may choose that those specifications just kind of floated. not to go back around, like girl hinges all the way around without weaving into the calcification, and then it sort of floats away. And that can be done too.
Yeah, I was just thinking like you go from the back and you say a guy comes back in 6 months and in 6 months it's like, oh, I feel a little worse, then you rearrange it and jump to you know that he's getting worse.
Okay, so I just have a comment. The comment of the statement of kyphosis begets kyphosis, is that 100%? It sounds like it. I know.
That's a dogma.
I know. I know that. I know it's not you, but I'm also pointing out, you know, that sometimes we use one dogma to define a lot of our decision making. Right.
Everything is true.
Yeah, but this is important, I think, because, you know, a laminoplasty for this is like an hour-and-a-half operation. And if it treats the symptoms and you just follow them and you've done a very simple operation to deal with the symptoms of the problem. Yeah. I'm just playing that advocate side. Yeah. Mm-hmm. Mm-hmm. Right. Right. Yeah. Okay. All right. This is great. Thanks, everybody. So we're coffee break, bathroom break, and we'll come back around 2:15, 2:10, 2:15. Okay. Thank you. The next theme that we're going to talk about is kind of it's kind of two things because they overlap a lot, and that's degenerative scoliosis and also lumbar stenosis. So kind of a combination of those two things. Dr. Leonard is again one of our great rehab colleagues here, who's been doing this for a lot of years. So he's seen a lot of the new stuff and the old stuff and everything in between. So he's a really good resource for how to treat things and what to do. So thank you very much, Dr. Leonard.
Dr. Brooks, thank you. Thank you for inviting us. And our rehab department division is very thankful for neurosurgery to join us in on this. It's elevating our pain fellowship and elevating our residency. So it's really is extremely beneficial. So you're right, I've been doing this a while, but the more I do this, the more humbled I get. You know, there's about 200 different approaches for spine pain that are listed as treatment approaches. I was humbled the other day. I sent a patient for massage therapy. They had a 3-month wait before they could get into anybody in town. So and the massage therapists are on a cash only basis are doing much better than the rest of us. So just be aware of that. So this is a case that kind of molded my thinking for a long time. This was a 17-year-old girl, originally from the Upper Peninsula, Michigan, that really had some pain, and she was sent to me for some mid-back pain. The first picture on your right was taken, and then the second picture was 6 months later, and the third picture was 6 months later after that. What it turned out was she had spinal muscular atrophy, and it was diagnosed along the course of this. The take-home message from this was it was impressive how quickly this progressed in the space of 9 months to a year, and it instilled in my mind that we do need to be cognizant of the impact that the paraspinal muscles and the muscle groups would have on the spine and what impact it would have. So it was very impressive. She ended up having a fused thoracolumbar fusion by a good Dr. David Mann, a pediatric orthopedist here about 30 years ago, and did very well. Of course, since she had issues related to her spinal muscular atrophy along the way. There we go. Sorry. There's kind of 3 issues that go on that I deal with in the rehab world. obviously the scoliosis. Functionally, what a lot of people come into the clinic is more of an issue with the kyphosis along with that, or in spite of it. They're tired of looking at the floor. There's a lot of times it's stenosis that will force them to look down, but many times it's just the progressive kyphosis and scoliosis that will have an impact on it. So looking at that and seeing how they're functioning along with that is huge. So I think what I like to say is we're functional rehab in the spine clinic. Obviously, we want to rule out the surgical issues from the start. The psychologist, our pain psychologist, say, look, you have the most power over the patient with your first visit. And so you define what you can do, what their role would be, and how long it's going to take. So you put a limit to what you can do also as far as your time frame. So the patients come in, I like to see what do you want to do about this? How limited are you? It's kind of interesting. The worst kyphoscoliosis we see are actually those that are more in their late 70s, 80s, 90s. And we're finding is that they really didn't start screening for it probably till the 60s or 70s. In some of these cases were just let go, and now they're dealing with the long-term sequelae of it. So that's has a big impact on it. So I always say, look, we got to look above and below, outside and inside, see what's going on. We look below, what we got to look at. A lot of times issues are related more to the hip. This is an example of an ankylosing spondylitis that was associated with a kyphosis. There's also degenerative changes to the hip, and while the kyphoscoliosis was there, you can see the degenerative process that are occurring in the hip itself, bone on bone, and somewhat of deformity of the head. That was really the issue. So along with that, you want to see what else can maybe occurring. So a lot of times the issues with the lower extremities, we think it's due to the stenosis, but actually there's a big contribution from a vascular component. And so it's more and more frequently I'm checking ankle brachial indexes, checking the vascular studies to see what may be going on with that. In addition, there's probably a small percentage of the population that come in and they hurt all over, they have the scoliosis, but it turns out they have an inflammatory disorder such as polymyalgia rheumatica. And so being aware of that would also help you in your evaluation of it. And along with that, this is Wisconsin. We are noted to the state. They have the highest drinking averages across the country. And so like Dr. Trost was saying, a detailed neurological exam would make a big difference. Dr. Resnick stored all the rooms with 120 hertz vibratory forks. And, I'll touch light touch and they'll say, yeah, it feels fine. But boy, the vibratory tool really is good to pick up the neuropathy. So keep that in mind as you do your evaluation. In addition, you say, well, the young lady had spinal muscular atrophy. Well, she had a problem with too little muscle mass. Well, in the early 1900s, the French looked at that and said, why don't we put these kids with scoliosis in scoliosis schools, have them exercise several hours a day, and maybe that'll correct it. So they did that, and what they found, they had very, very muscular kids with crooked backs. So it did build up, but it really did not correct the scoliosis. And I think that's the same issue with our bracing is it will limit it, but it won't correct it. Along with that, for some reason, we're seeing a much higher incidence of hypermobility in young individuals that come into the clinic. And there's the Byton scale. Dr. Nathan Rude, now the pain clinic, has developed a clinic for Ehlers-Danlos and become hugely popular. But just looking at their flexibility, are they too flexible? That's what's setting them up for the scoliosis, the progression of it. A good thorough evaluation would help you look at that. Along with the scoliosis, we worry about the curve progressing, but as in this case, as she's about 80 years old now, along with the curve increasing, there's a lateral listhesis that has occurred that has resulted in a lot of more stenotic type symptoms going into her lower extremities. But really what happened, she was having pain along her left iliac crest. And what it turned out was her rib tips were hitting on the iliac crest from the curve progressing that much. So the simple solution was I put her in a support to pull the ribs off of the iliac crest and that gave her more symptomatic relief than anything. You guys could have done a, full surgery on her, but we'll try to get by with the simple support along the way. So, just the associated things that could occur. Individuals come in and say, hey, I'm really getting fat. Well, they're so kyphotic that their stomach just bulging out. I haven't seen too many that have had the pulmonary issues on it. We always talk about that. On bad cases, more in the pediatric, they'll get pulmonary function studies. But most of mine are pretty stable and are not progressing, even though Cliff DeBue has lectured a lot in the past about, well, once you get about 50 degrees, you increase about a degree a year in your angulation. But most of these fines are pretty well fixed, and so that's a part of it. Along with the lateral ascesis, Michael Seward was talking about the facet generated changes. So you could piecemeal it and just try to see where the pain is. Perhaps the pain is here where the facet degenerative changes is, and that may be the thing that you need to focus on. I'm not as good as far as picking up on the true, is it a balanced sagittal curve or coronal curve? But when I see a case like this where it's really off to the side, I'm going to send them much more quickly towards your direction in the spine area than I will keep them. This individual actually did have a dextrocardia, had a loss of ribs up in here and a deformity with her curve going to the left. So those congenital type of anomalies we'll take a look for. Every once in a while, we'll pick up a tethered cord type of issue that we feel that probably had an impact on it. But that's really quite rare, but we always keep in the back of our mind. With the kyphosis, I will obviously try to do some way to get their eyes up so they can at least take the stress off their back. Most of these individuals are a little more elderly, so they are more compliant with this type of thing. They're used to it. And it's true that the corsets don't help all that much, but it does keep them functional. Many times they'll increase their walking mobility a great deal. So that can be effective as far as a way to approach it. For the kyphosis, yes, a simple figure of 8 support to pull the shoulders back can make a big difference. I have put people in braces that will a cash brace, cruciform anterior spinal hyperextension that will extend here, here, and here and hold them upright. But those usually put too much pressure. So it's a matter of, is it really worth the comfort and will it keep them going? It's hard to do for scoliosis. It's hard to do specific strengthening. And actually of all the studies over the years, the most effective exercise for any spine pain is aerobic exercise, period. That's the only one that's been proven. So if I can get them to expand their chest and keep the ribs mobile, they many times cannot walk because they can't stand erect with the pain in the spine. And so the recumbent bike has been a lifesaver for those. There's a device called the New Step with alternating arms and legs where they can do the strengthening exercise and really get their heart rate up without irritating it. If someone gets into the water with up to their chest level, they decrease their weight by about 75%. So that can have a very positive impact. But in Wisconsin, outside of Madison, there aren't too many pools and a lot of people don't want to do that. So that's with limited effectiveness. Even just doing simple exercises that are taught at home can make a great difference. The issue with this, you got to keep seeing them. If you get compliance up, compliance with exercises on home is about 20%. So it's really an issue. If you can get them walking, that's probably the best. The simple hiking poles or a walker, they get that shopping cart effect on it, and they'll go twice as far as before. So I will write for a wheel walker with brakes so that if they have to sit down and a seat on it, they can do it. But whatever you can do to get them moving, just do it and encourage them to do that. I push the idea of weight loss. I give the story about for every pound of fat they lose, there's 7 miles less of blood vessels in that pound of fat their heart has to pump. So I said, get rid of 10 pounds and your heart doesn't have to pump a blood cell to Lake Michigan. They'll do it a little bit, but it's hard to get them to lose the weight. The bariatric program here is focused much more on the non-surgical aspects of weight loss, to the point I think they're following about 1,000 patients now and starting a new team. So that's becoming much more popular. Is it cost effective? Absolutely. But just to prehab someone before one of your surgeries is a huge difference. The trunk muscles, obviously they can't do sit-ups, but just to look at core strengthening. And if you give them 3 to 5 exercises they would do regularly, you're lucky if they would keep doing that. So the basics of the rehab program is really simple. Is you have to know what to do, what their goals are, and how you can get there within their lifestyle. Most pain is a lifestyle type of issue. Keep in mind that with children with scoliosis, they don't have pain. So where's the pain come over the years? The degenerative changes around it, the disc degenerative changes. And so you're looking more elderly population, you got to get them working within their goals. So you try to keep their range of motion. It's hard on someone in their 70s or 80s to gain much. There are studies that show you can really improve the muscle mass by consistent exercise. So you have to do that. The aerobic exercise, perhaps a brace, and then get into the other things that have been well addressed before, such as the injection approaches. But I always tell them all these approaches will give you short-term relief. They will not correct the problem. There is a small set of the population that have failed either surgery or are too limited to do surgery, that is reasonable to consider pain medications on a low dose on a regular basis to keep them functional. It is a limited group. Individuals that have an addiction will continue to ask for more discomfort. Those that have pain will tend to stabilize and stay at that dose. And I have a small subset population that we really can't do anything else with. To give them some pain medication so they can keep functional is a reasonable approach, but it's you have to watch them close, and it's highly restricted, and the current culture tends to go against that. So how frequently should they be followed? The majority of these cases are seen in the primary care clinic. Probably we're seeing, you're probably seeing a very small subset of that, probably less than 5%. I probably see maybe 10 to 15% that will follow long-term. Some of it is the primary care is too busy to follow them that way, and it just works better in the clinic. What we find in the spine clinic is they will come and they will tend to stay because they don't want to leave the clinic setting. And so that's an issue to move on. If someone has a neuro deficit and are just getting functionally more and more limited with their stenosis, with their scoliosis aspect on it, yes, we'll send them for surgery. But I try to define with them, okay, what's your goals? You know, you really feel you can handle this and progress into it? Then they will talk to the surgical folks, but I find our surgical group here actually quite conservative as far as how we would approach this, and I think that's to the credit. So Dr. Brooks, I'll let you take it from here in the surgical aspect.
Okay, thanks a lot, Dr. Leonard. That was great. I think it is valuable to know kind of what the thought process is for treating scoliosis in the non-surgical world, because we're very this is one, especially in the last couple decades, this has become kind of the biggest growth aspect of spine surgery, at least in the neurosurgical side. Just talking about degenerative scoliosis and what to do with it. The vast majority of that is related to again the age of our population. How many people are getting old enough to develop degenerative scoliosis? The prevalence is roughly 38% of the population of people greater than 60 years old, and then more prevalent in females than males. It is degenerative scoliosis is different than some of the other things that Dr. Leonard was showing, is really just the age-related changes of the spine. So an asymmetric degeneration of the spine, which eventually, unfortunately, develops into a deformity, and then we don't know. We don't quite understand all the causes, of course, like many things. There is always that thought process that maybe there is a musculoskeletal or a neuromuscular phenomena also associated with it, just very localized, is still being researched. So it's important to know. It comes with a range of symptoms. So my mother, who's 80, has terrible degenerative scoliosis. And you could tell by looking at her, but she has no symptoms. It never stopped her. It causes no neurologic complaints, no muscular complaints. that she complains about. Then you have that all the way ranging from back pain, which may be from the scoliosis or may just be the back pain from myofascial or any other number of causes that we discussed already. And then neurologic, which is a little bit easier to understand and to diagnose, of course, because we get our radiculopathies and our neurogenic claudication and those kinds of things. But those kind of broad ranges also make it harder for us to know whether these patients need a surgery or not. But it certainly is a label that leads to them meeting a surgeon. Okay, and that's why we try and train the surgeons here to be more conservative, because it's the surgical treatment is dangerous and expensive. So this is from a case, a deformity case I did, and this is all the equipment that they had to bring. This is a truck pallet. Okay. Now that covers a lot of different bases, and we're not going to use all that stuff for that particular operation necessarily. But that is how much stuff you can, how much you can use to do the operation. And that's just the cost associated. And then of course there's the risks associated, and we'll get into that. The types of problems that patients will have will be mostly related to global balance dysfunction, but also can be neurologic. This patient has really bad sagittal balance, and you can see that his head and his shoulders are ahead of his pelvis. You can also see Dr. Leonard will easily spot this shoe lift, so they already caught that and tried to correct some of his pelvic obliquity and those kinds of things with a shoe lift, which can cause coronal imbalance. When a patient has this kind of sagittal or this type of spine imbalance, the most significant one is sagittal imbalance, and they essentially lose the center of mass of their body, the control over it, to balance it over the pelvis, which is the easy way and the most biomechanically stable and comfortable way to stand erect. And therefore they get a lot of pain in their back, but they also get pain typically in their thighs, because they will try and compensate. They'll try and tilt their pelvis forward to compensate, and then they'll try and squat to compensate. This patient, you can see a little bit, his face is a little bit covered here, but he's also had to extend his neck in order to see forward, so they get neck pain as well. And so you get all of those as part of the syndrome, and that's just for the biomechanical part of things. Disability and pain seems to increase when you have sagittal imbalance greater than 5 centimeters, and when you have coronal plane imbalance greater than 4 centimeters. So those are some of our landmarks, although those are being modified over time, because again, as people get older, they develop kyphosis as part of the natural progression of aging, and we're still trying to sort out whether we're treating normal aging or an actual problem, and so that those numbers are getting a little bit larger in the older populations. You also can see true instability, either a flexible curve of the spine where when they're supine, the spine will straighten out, and when they stand, it will collapse, or things like lateral subluxation, where the bones will shift laterally and either cause pain, mechanical pain, or neurologic pain. The imbalance will cause increased metabolic demands, changes in heart rate, oxygen consumption, et cetera. And it's a lot of work. So that's mostly what patients will describe to you, is that they can get up for a little while. If they don't have leg pain, they will get back pain. Okay. And then it will be benefited by leaning on a shopping cart, but it's mostly the back pain in a mechanical way, as opposed to a neurogenic claudication way. This is an example of what the deformity corrections look like. There's quite a bit of hardware, as you can see. This anterior approach, posterior approach. I used to do these all in one day, but I got some sanity and started to do them in over 2 days, just because it was getting too exhausting. In some locations, they will actually do it with 2 teams of surgeons, just to try and offset the extent of work. you'll see patients will get mechanical back pain or instability pain and radiculopathy as well. These are both, again, a review of those numbers. Evaluating and managing these patients, seeing them, deciding what to do. Clinical evaluation is key. And of course, getting a history and getting a better understanding of what their limitations are and why. Because if you're fixing a problem, but you're not fixing their problem, that can lead to a very disgruntled patient. And if you're doing a very big operation to fix that problem, it's very dangerous. That also can lead to all sorts of unhappiness later on. Radiographic evaluation can include MRI scans, of course, to looking for neurologic compression, scoliosis x-rays, dynamic scoliosis x-rays, treatments. Sorry for everybody in the room that doesn't do surgery. We just call you just roughly conservative therapy, but I know you do a lot more than that. Okay. And I know there's a lot more than that, and things like injections and exercise and all those things. We've already seen this picture once before. The clinical evaluation is very simple. Stand them up and walk them. Okay. So I always tell the medical students that the most important thing you can do is get the patient out of their chair and walk them around the room or walk them down the hall if you can. You pick up a lot of things that way. You would never really be able to tell how bad this patient's sagittal balance is if you didn't stand them up. Okay. So sitting is not going to be a way to figure it out. And sometimes on the x-rays, they cheat, they'll lean on something, they'll push a little bit. So it's better to see them in their natural environment. MRI scans will of course show you any neurologic compression, but they can be a little bit hard to read as the slices of the MRI will go through lots of different planes of the spine at once, which make it a little bit more difficult. Standing scoliosis films, and you can see that sagittal imbalance and coronal imbalance in this patient. Supine bending films, again, it's hard for patients to really show the flexibility of their spine when they're standing because they're already have it loaded, and that's usually their most painful position. So you can't really see how much flexibility they have when they're standing. So we'll get them supine, and we'll do supine lateral bending films to get a better idea just about the coronal deformity. The sagittal deformity is not as easy to sort out, but can be sometimes sorted out. I'm not going to take you through all the different measurements, but there are quite a few. Sagittal imbalance is the most common one we talk about, or the sagittal vertical axis, and that's measured from the centroid of C7 to the posterior aspect of the L5S1 interspace, and that's just that distance, a simple distance. There are more parameters than that as we were learning about this, about how recontouring the spine. So it gets pretty complicated pretty quick, looking at the pelvic parameters and how we match those to the lumbar lordosis and those types of things, all of which are extremely important for surgeons, not as important for the non-surgeons. So I'll spare you all those details. What else can we use? So selective nerve root injections, whether they're diagnostic or therapeutic or a combination of both, just to help us decide, are they having a radiculopathy? How can we deal with it? Is it necessary to do the big operation, or can we just fix the little thing? And so that's where you have to get into the subtleties and nuance of this problem and realize again that you don't always have to fix the picture, you need to fix the problem. We can, as far as treatment options from a surgery perspective, you have decompression options, which typically are focal decompressions, not long segment decompressions, limited fusions, or the big deformity corrections, the pictures you've seen before. I typically will try to find the least dangerous, most effective option. Okay, so and I also will talk with the patients quite a bit about the options, because the decompression surgeries are simple. Many times they're outpatient operations, and if they fix their symptom complaint, whether that's a radiculopathy or even some degree of neurogenic claudication, it's not that dangerous. If it fails, I still can go on to the next operations. Whereas if I do the big deformity operation, they have a bad complication, I can't ever take that back. So it's really a discussion like that. Many of these patients are older, and they've for the most part have found some reason, and will listen to reason, and they try and find also the least invasive type of thing as well, if they can tolerate it. So there is some efficacy to that. The studies are not that great, but still, I've done that more often than not. You'll see me doing a deformity operation on somebody I've already operated on, because I've tried to do something simple or small for them. Limited fusions are really tend to be targeted at, say, an area of instability or an area of potential instability, depending on what your surgery might do. As an example, lateral subluxation will usually cause a lot of stenosis and pain, and sometimes you can just focus on that laterally subluxed level, do a simple single level fusion, and again, counsel the patient that you may be back for something else, but not always necessary. Just depends on how long they live or you live. Lateral approach, so MIS approaches are other ways that we can deal with deformity that have also changed kind of the risk calculus. So some of the MIS approaches have helped us decrease blood loss, decrease soft tissue damage and exposure, and that's made things a little bit easier. The residents know that a lot of times I'm trying to do anterior approaches for as much as I can, because there's just less blood loss and less overall exposure, but usually couple that with a posterior approach as well. And you can see that in some cases you do have to do really extensive surgery. This patient has really bad coronal imbalance and also sagittal imbalance, and you have to deal with both of those things. And sometimes that requires a large posterior approach, because you have to manage all the different degrees of freedom, anterior, posterior, and rotational, to get the spine into a better position. Decision points, neurologic dysfunction really drives a lot of what we do. And again, we've said it many times during this conference, it's a lot easier to know what the outcome is going to be of decompressing a nerve than it is to stabilizing an area of the spine. Mechanically stable or unstable, if you can find a truly unstable area in your workup, then you have a much better likelihood of success. So that's the key. If the deformity looks like it's static or really glacially stable, then sometimes correcting it or stabilizing it further doesn't seem to be that beneficial. Dealing with global balance, like we talked about, is sometimes important. It can be very important depending on who you are. So again, when you go to meetings nationally and internationally, typically the people that are talking about balance parameters are also the ones that are subspecialized in dealing with balance problems. And so they get referred all the things that have failed, and rather than having kind of a general practice, they have a very specific practice. So they basically say, if a patient comes to them, it was a failure, and then they look back and say, okay, they did this one operation, they did this operation, and they should have never done that, right? But as you can see, because I kind of have a bit more of a broader view of it, sometimes a little operation works, and they would never go to that person. They would never be seen by that subspecialist. And so you just have to keep that in mind as you're deciding how your practice is going to work. And you have to keep in mind also that cost to the patient, cost to you, and that cost can be danger to the patient is the most significant one, because these operations are not little. Simple decision points here. We have lumbar stenosis with what we call stair-stepping spondylolisthesis. You don't want to make this permanent, so you would probably want to do at least a focal well, I'll say focal in quotes because it's still a big operation, but an L3 to S1 fusion with interbodies to try and bring the lordosis back, to improve the lordosis, as well as deal with the lumbar stenosis. If the patient really didn't want to do that, yes, we could do it, but I'd follow them over time and get a better idea if they're gonna be able to deal with that. But this is more like know when to run. Okay, so this one came to me as an adult, but this is a congenital deformity. Okay, and they have back pain, of course. Everybody has back pain, but the question is, do they need an operation, and will the operation help their back pain? And that is really going through the workup, going through old films, going through all these kinds of things have to help you sort that out. But even at the end of all that, when you look at the danger involved in doing this operation, it is more likely to harm the patient than help the patient. So you have to always keep that in mind as you're coming up with treatment options and treatment plans. Overall, if we treat sagittal imbalance, we tend to see a pretty large improvement in oswestry disability and also SRS 30 scores. So these are just patient outcome measures. And so in conclusion, degenerative scoliosis is very common, and we really do need to take a nuanced approach and a very holistic approach to treating patients. I haven't even added into this talk the fact that almost everybody has osteopenia or osteoporosis, so it's even harder to deal with, but that's important too. So, thank you, everybody. So I just want to switch over to the cases here. Dr. Leonard, if you'd move up to the front here, and I will bounce back and forth as we get our cases going. Thank you. All right, thank you. So I guess I wanted to talk with, a bit about, as you guys have seen, kind of gray area cases, but I try to make them seem a little bit easy on the face of it. So this is a 75-year-old with neurogenic claudication and preserved sagittal balance. The only thing hard about this is they absolutely do not want to have surgery, but they still have some back pain and back discomfort and things like that. They really want to see Dr. Leonard and get his opinion about what he can do or thoughts on it. So if you would.
I think way on? Okay. I think the big thing is, how limited are they? Look at their functional limitations. The first thing I try to restore is their sleep if they're having trouble at night, and look at pharmacological approaches. And then during the day is what's their comorbidities? Probably in someone this age, how much can they really do, and whether they tolerate. So do we give them medications to mask the symptoms? Well, they can try to work through it. We give them a brace to mask the symptoms. Do we do an injection to try to take it along? And I will list out options conservatively, going from the least limited, which would be home exercises, medications, and bracing. Going to the next step would be injection or other interventional approaches. Going to the next step and give them surgery. And I lay those three options out the first time I see them and see which one they pick. So those that are really in tune with taking care of their body and doing it themselves will go with the more conservative approaches. Those that want a surgeon to go and fix it will ask for that. And I'll say, everything I will do will give you short-term relief. If you don't feel you can handle this anymore, even if it's mainly back pain, I say you're not going to be a surgical candidate. If they're over 250, over a BMI of 35, they're not going to be a good candidate. I'll tell them that they got to achieve their goals. And if they're willing to work at it, I'll give them some pain medications to control the pain so they can do it. But then I just got to set a limit and a time limit on it also.
Yeah, so I think that's great. And I know you talked about this in your talk, but just giving them a wheeled walker sometimes is all they need is just the ability to get a certain distance and then sit, and then start over. So my neighbor, who was a very nice, 77, 78-year-old guy, he basically said, I do not want to have surgery. There's no way. He sat down with Dejmuk for like an hour and a half, as you would expect that conversation to go. I don't want to have surgery. And so he for as long as he could, he would still mow his lawn, which he loved to do. He put a chair in the middle, and then he'd just go to the chair and to the chair. He'd mow each thing, and he just figured out a way around it. And eventually got a ride on mower, et cetera, et cetera. But they sometimes that's all they just need an idea to like move forward with what they want to do with their life, but they may not want to actually do surgery. They just need help with it.
The nice thing about this population, they're the most straightforward group you could work with. And you get in this age group, they'll have reasonable goals. They have a better perspective on it. They probably have less anxiety than a lot of the younger individuals. Not a negative comment, it's just a fact.
Yeah. It's true, although not perfect. When they just retire and then they realize they have neurogenic claudication and they want to go to Europe and all that stuff, then they
Yeah.
become very much like young kids again. They're like, I want to get this fixed and move on. And so
Yeah.
there's that crowd too. Yeah. Usually by 77, they've done all their travel.
I remember that. Okay.
Yeah, exactly. Thoughts on interspinous spacers, things like that. Anybody have any?
Insurance
says
quit paying for
no.
that, didn't they?
Yeah.
Pick it up.
Well, you're the only one who would take them out. So you're biased.
Terrible idea.
Okay,
Because
Kat?
they do these very fine spacers with- they have surgery, but all it does is the fingers.
Right. So I think there's certainly those sides of things. What do you think? Anybody? Coflex, X-stop, anybody? I know it's not, we are definitely don't do that kind of stuff here, but I know it's still done, and it happens. So for the residents, if you don't know what these things are, these are just ways to put the patient into a kyphotic posture focally. So they put a spacer in between the spinous process. There's, yeah.
Give it more movement. If someone can't tolerate the operation for some reason, it's an alternative, but it's.
What about the mild procedure? What about the mild procedure? I love hearing truth versions of things. Do you know what the mild procedure is? Decompression, yeah.
Yeah. With a wire.
I think I don't know exactly how that's done, but I don't know, any of the fellows seen it or done it, or? Pulling some ligament out, basically under fluoro.
Is it for suffer, diameter decompression?
Yeah.
The-
They just pain in the ass to apply. They create a disc. Maybe that spot is hard to set. And it's not a bad operation if they never have to have surgery.
So I think these kind of, I bring up this topic because we're starting to see a gray area between what is like the proceduralist world and what is the surgical world, because things are kind of starting to overlap a little bit as they become less and less invasive. And so I think it's just important that we all know what these things are and at least can talk about them. So I think it's a question of whether they functionally do anything. Anybody done them? Yeah, Kat. Uncomfortable. Yeah. Yeah, but I think it's an important, it's important to know that those things exist. People do them. Whether the efficacy is there in selected patients, that's still hard to know. From the surgeon side, we would think that would be quite frightening because again, the way that it's done is under 2D imaging without any knowledge really of what the structures are, other than knowing that the ligament is relatively firm compared to dura, and then bone is easy to palpate. But we see the same kind of phenomena happening in endoscopic spine surgery, where people think because it's a tiny incision that it must be pretty safe. But in fact, as you guys have seen, it's the same exact thing. It's just miniaturized and still just as dangerous when you get down there. So these are important aspects. And then, like Dr. Trost back in the day used to do this totally percutaneous procedure called chymopapane, which worked great in his hands. But what happened when it got into everybody else's hands?
The reason it partly is because people use it for the wrong reason.
Correct.
It's simply just this.
Right.
Period. It wasn't anything else. And so people would have an error in place to exactly dissolve all the nerve roots.
So chymopapane was a protein. Chymopapane would.
People maybe just people who are back pain, which I didn't really see. The guy was fine sharing with hundreds of them. The column is so big that and they develop already this. The third thing they develop a lot of that. All those developments guys all along the time. And I don't think that's true. I think it's considered they did it. And it's also good. Probably something back in this.
So, I mean, the thing about it is like, that when the procedure was done, it was studied well. It was, the people that did it were experts at doing it. And then when they got very good results from the randomized controlled trials and everything that they did. But the problem was once they let it out into the open market, people didn't know what they were doing or why. And so the reason that it stopped becoming used, even though it worked, is because people would die. They would inject it intrathecally. They'd get arachnoiditis, or they'd have seizures, and they would die from this. And so even though it was an effective treatment, it was very dangerous. Yeah, that's I'm bringing up the point that we have this kind of bumping ahead of the procedure side, and that can be anesthesia, rehab, radiology, and then surgery, and they're kind of like meeting in this little area, and we just have to be cautious about how because Kath, you kind of like point out you did it in fellowship, but you don't feel as comfortable about the idea, knowing the anatomy. Yeah, no, that's kind of how it starts. People go to a 2-day course, and then they start thinking up the indications, and you realize that that's not enough. So make sure you get dinner. Yeah, because you had that. Our last theme is pretty long, so I'm going to skip our last case if that's okay with you, Dr. Leonard. But thank you very much. Appreciate it. Thank you. So the last topic is pretty straightforward. It's just back pain. Okay, which is so easy. We left it for last. I think that this is one of the more challenging topics in spine care because it is extremely common. There are a million different treatments for it, and it's unclear which ones work and which don't. But patients just keep coming and coming and coming, and they always want to hear more about what the options are. What we learned in surgery land is that we really didn't have an understanding of what the pain generators were, and the only treatments we could come up with were pretty drastic. So there certainly is a lot less surgery done for just axial back pain. But I think it's certainly worth discussing. So we'll start out with non-surgical treatment with Dr. Glinka Shibic, who is going to give us the rehab perspective. So appreciate that. Thank you.
Thank you, Dr. Brooks, and thank you for this invite today. I'm Allison Glinkashibish. I'm one of the rehab doctors here at UW and also carry the interventional pain title. And even though that interventional part of my practice is more prominent, I, really when I'm working with patients, talking a lot about this full spectrum of care that involves many different modalities. And I think it's important, this talk was great for me to kind of review some of these things, looking at the evidence for when I'm talking with patients about things like physical therapy, acupuncture, mindfulness-based stress reduction, CBT. These are all things that we offer, most of which in the pain clinic. Acupuncture, osteopathic manual therapies are within integrative medicine, and I often refer my patients there. And then medication management as well, talking about non-opioid and opioid pain medications. On the right here is this this diagram looking at the facet referral patterns, and I'm just sort of bring this up in general. My talk is going to be more about back pain treatments, low back pain treatments in a general sense, but always sort of thinking about what are the true pain generators and how do I match the appropriate treatment with the cause of pain. So, when we think about physical therapy, I'll often see patients, and I think Dr. Poliak-Tunis referenced this as well. People will come in and will say, "Oh, physical therapy didn't work for me." And for my part, sometimes I think, I'll ask them like, well, what did you do during physical therapy? Was it, something that was targeted towards your symptoms, or was it just more of a general, did they just sort of throw you on an exercise bike or something like that? So I think, one can find, the narrative in the literature. There is this first study here, from JAMA as a randomized controlled trial, showed that PT for back pain wasn't actually all that effective in reducing disability. Or it was, minimally so. And then the sort of newspaper headline becomes, well, PT doesn't really, help patients with back pain. But the reality is, there are large systematic reviews that show that physical therapy and very specific types of physical therapy can be helpful for patients. I think that, when we look at, there's exercise for chronic low back pain, carries a grade A recommendation, manual directed therapies. And then a lot of the time, that our physical therapists spend with patients is around neuroscience education, what are the causes of some of their pain, and then adding in active treatment modalities in addition to their exercise plan. So things like yoga and Pilates. One of the things, we also want to think about what are the treatment options within physical therapy that have less good evidence. And so things like mechanical traction, a lot of patients will ask me if they can go get a traction device. And I think, when we think about, the grade A evidence is this a number of level 1 randomized controlled trials. Grade D evidence is still expert opinion. So it's not, certainly not as robust. And then things like general exercise after spine surgery carries a sort of grade C recommendation level. In addition, I think it's important to consider the effects on medication consumption. So early physical therapy is actually associated with reduced opioid use. And there have been multiple observational studies showing, looking at, reduced use of opioids when we introduce physical therapy early on in the treatment plan. Typically, when I mention things like acupuncture in clinic to patients, I feel as though I get a little bit of pushback. I like to sort of have this discussion about, there's actually a tremendous amount of clinical research, randomized controlled trials showing that there is benefit for chronic low back pain. I'd say more of the literature actually is supports for migraine, use of migraine, for headache, for acupuncture, but for chronic low back pain, CMS actually started covering acupuncture in January of 2020. So sort of built upon a good amount of research that shows that there are good durable effects with these treatments. I think we also sort of talk a little bit, and this is more so at when I work and see patients at the pain clinic, but about this sort of mind-body connection. And I think this is one of the harder things for people to grasp. At a certain time, I feel that, you know, we didn't have a lot of research sort of supporting these ideas, but things like mindfulness-based interventions, there are good quality randomized clinical trials that support this work, and in particular, you know, the reduction of pain, improved function, and then looking at actually decreased consumption of medication as well. And this is ongoing research with this trial here. The STAMP study is actually something that University of Wisconsin, multiple other multi-institutional study recruiting patients. So it stands for Strategies to Assist with Management of Pain, and looking at meditation, sort of combining meditation and cognitive behavioral therapies. Another part of this is really looking at you know, the medication. So these other therapies that I've talked about so far are not ones that I'm actually actively providing the intervention for or involved with, but I think it's I'm a big proponent of them. With the medications, you know, we do sort of more infrequently you know, prescribe medications for chronic low back pain. When we talk about these things, I think it's important. I mean, we're not going to really talk about the pathophysiology here, but we're kind of looking at, you know, the different areas where these medications act within the nervous system. But you know, we look at some of the medications that we'll use. So like duloxetine is a medication that is FDA approved for chronic low back pain. And it's one that in some larger systematic reviews have been shown to have modest effect. Other medications like gabapentin or pregabalin, we prescribe these quite often, but there's really insufficient evidence to show that they're you know, treating low back pain well. And those medications, both of them are really being used off-label. So their indications are more for neuropathic pain and sort of associated conditions. NSAIDs, you know, which we typically prescribe quite often. You know, there is strong evidence for this, but we have to use them with caution in particular patients. Acetaminophen, not great evidence at all for chronic low back pain. And then this one, you know, this is when I talk about lidocaine, again, off-label here, but we do lidocaine infusions for chronic pain, pain that's more sort of a central sensitization state. And then talking about opioids, pretty rare, you know, I think this is more a function of the sort of pendulum of opioid prescribing that occurs, and we're sort of at one end of that where we're not really prescribing many opioids at all for chronic pain. But there are randomized controlled trials that show sort of small effects, and the strength of evidence is sort of moderate. And I've talked before about, you know, or I use buprenorphine quite a bit in my practice, but it's typically, I don't typically initiate it. It's typically for patients who have chronic opioid use, and we're trying to transition them to something that maybe has a little bit lower risk for respiratory depression. So quick summary, take home physical therapy. A number of recommendations are grade A in terms of the interventions that are provided. Randomized controlled trials exist for acupuncture and for mindfulness, meditation, and cognitive CBT. But I would say that we do need additional research. We don't have the sort of same grades of evidence to support these interventions. And then opioid and non-opioid medications, there's really sort of weak to moderate evidence for these these treatments, and for the most part, many of them are off-label. And just because we do it frequently doesn't mean it makes it on label. You know, you know, there's a lot of the recommendations, and we use other antidepressants as well, sort of for pain, and we're really not seeing that there's the evidence to support that. So, and then with the opioid medications as well, we really want to sort of balance the risks and benefits, even if there is weak to moderate evidence to support their use. And that's actually all from me. I'll hand this over to my colleague.
Great. Thank you very much. So Dr. Pride works in the pain clinic. Kath, where'd you do your fellowship?
Oh, I went to Virginia Commonwealth University.
Virginian pain fellowship, interventional pain, but you were an anesthesia resident here?
Yes.
He's an anesthesia resident here. So you guys might still know him from then, but he's going to talk to us about interventional treatments for low back pain, which they're becoming more and growing. So thanks, Kath.
You guys hear me okay? All right, sounds like it. All right. Again, thanks, Dr. Brooks, and thanks for inviting me here today to discuss the very, very broad topic of interventional treatment options for low back pain, which is essentially my entire, job and occupation. So it's a lot to cover. I'm going to try and be concise for you guys. So common causes of low back pain, there are many. I'm going to try and talk specifically about more things that you as surgical residents would see, but also to my cheaper seats in the back with the PM and the pain fellows. So what we commonly see, or probably most commonly see, is something just called myofascial pain, which is more of a muscular related pain. And I'll discuss each of these in a little bit more depth a little bit later. But others include lumbar spondylosis without radiculopathy, lumbar stenosis, and other possible causes with radiculopathy, including lumbar disc herniation, as well as failed back surgery syndrome or post-laminectomy syndrome. Some other encounter diagnoses that we include or encounter and also use deconditioned low back, lumbar disc degeneration, as well as lumbar sprain and strain, and then just an easy one, muscle spasm. So. This is just to discuss diagnostic aids of some of those more common causes of low back pain. So the myofascial pain, this is something that can be elicited just by palpating across the affected muscles or muscular groups and finding these identifiable trigger points. This is not a very high point of this talk, so I'm not going to spend too much time on it. Next would be something called facet-mediated pain. This is obviously pain originating from the lumbar facets or the Z joints. Ways to identify that or help diagnose that outside of just the common complaint of low back pain would be pain with loading, so twisting the patient and then having them lean back to one side and the other, and then eliciting pain at that area in the lumbar spine of the low back. That coupled with tenderness to palpation over these paraspinal muscles, and also plus or minus osteoarthritis or spondylosis as appreciable on something just like X-ray. Sacroiliac joint pain syndrome, so obviously a little bit lower in the low back, but still can radiate upward, and something we see very frequently. Most commonly caused by osteoarthritis of these two large joints. Finding in order to help identify and diagnose this is just something called a Faber test, where you have the patient kind of cross their legs. It's an acronym: flexion, abduction, and external rotation. And then, of course, tenderness to palpation across those two large joints. And then lastly, this post-laminectomy or failed back syndrome, failed back surgery syndrome. This is a chronic, long-standing low back pain with or without a referred component. And these patients typically have had one or multiple surgical interventions that have failed to treat pain. Even though oftentimes surgical interventions are obviously there to help treat a lot of other things like neurologic deficits, blood or bowel and bladder deficits as well. But this one specifically targets the complaint and symptom of pain. So let's start off with lumbar radiculopathy, and most specifically epidural steroid injections. So the epidural space can be accessed in a multitude of levels and a multitude of ways. It's one of the most widely utilized pain management procedures in the world. Its use is supported by a whole host of studies as defined there. And despite this extensive amount of literature, there still is a lot of controversy around how often you should do them, where you should do them, in whom you should do them, and to what extent you should do them. So, sorry. And the last bullet, the results of a lot of clinical trials are heavily influenced by the specialty that holds a clinical trial or that participates. So with those being done by interventional pain physicians, obviously more likely to yield positive findings. So. In that same vein, typical ways to access the epidural space, interlaminarly being one of the most common, second most common, probably transforaminal, and that bullet point noticing that transforaminal injections are a little bit more likely to yield positive results rather than the interlaminar approach. And also there was a subgroup analyses that indicate a slightly greater likelihood for a positive response if there is a notable lumbar herniated disc compared to just a more generalized spinal stenosis or obvious axial back pain. So. Randomized studies conducted by spine surgeons in surgically amenable patients with standardized operative criteria indicate that in some patients, the strategic use of ESI may prevent surgery. And that was just noted in this comprehensive evidence-based review I've noted on the bottom. Said that word for word because I didn't want to mess it up. But I think everybody has their own kind of viewpoint on epidurals and whether they should be used, as well as the administration of steroid and its positive plus or minus deleterious effects if administered over the long term. And so this is something we as physicians and specifically as interventional pain physicians have to really consider with each patient that we choose, especially the age that presents to us and how active they are and what is our end point and what is our goal, right? Is it to get them through physical therapy? Is it to improve their quality of life in the short term? And then all the other decisions we need to make. Can they lie on a table on their stomach? You know, can they endure the poke of a needle? Some of the imaging that Dr. Brooks had up there of some of his more notable patients and their scoliosis, I don't think I want to even see them on the table or under x-ray, much less try and gain their epidural space. But, patients like that we do see, maybe not to that necessary extent and not necessarily too commonly, but their risk significantly increases, as soon as they endure the pinprick of my needle. And so that's something that we have to take into account as well. Myofascial pain syndrome. So again, this is a palpation or the identification of something called a trigger point. It's where you palpate across this muscle and try and find a taut band. A way to easily treat this is do something like a trigger point injection, which is typically performed with something as small as a 25 gauge needle. Some providers and interventionalists use something larger. Usually it's the administration of the needling and the mechanical lysis from that creates the actual therapeutic effect. It's not the administration of the injectate, whether it's saline, steroid, or local anesthetic. That being said, I personally use local anesthetic, but at the same time, it's something that I very, very commonly do, and probably most commonly in the low back as well as the cervical spine or cervical spinal paramusculature. This is just a randomized controlled pilot trial that discusses trigger point injections used with lidocaine, specifically by my ER counterparts, and how it showed improved pain compared to other conventional methods that they used in the ER setting, and also reduced their length of stay and also reduced some opioid prescriptions on discharge. I'm not going to speak too much about the placebo effect of these, but arguably just to give you a gestalt about what I see and how frequently I see it. Low back pain is my most common target. I'll usually do anywhere from 1 to 8 of these injections on a patient, administering anywhere from 5 to 10 cc's. I use personally 0.25% bupivacaine. I don't perform it any more frequently than every 8 weeks, but I usually push patients to every 10 to 12 weeks, unless they're very adamant about wanting it or needing it. It's a relatively very low risk procedure and something that can easily and pretty quickly be done by somebody like me. So. Facet-mediated pain. So this is what I alluded to earlier. This is AKA lumbar spondylosis or facet arthropathy. These are those facet joints or Z joints in the lumbar spine, and that's how you diagnose it. Interventional treatments that we have to treat this include intra-articular steroid injection into the actual small joints, which is that X-ray you see in the upper right-hand corner targeting that looks like 2-3 and 3-4 there. And you can see the little vertical interarticular spaces here in the needle and the corresponding needles. This is a picture of targeting the nerves or the medial branches that innervate those joints. And so how we commonly treat this if we're not doing an intra-articular joint injection is we do these nerve blocks, and then we subsequently do radiofrequency ablation of these nerves if the nerve blocks are deemed successful. Successful nerve block is relating greater than approximately 80% of pain relief over the course of 6 hours or whatever local anesthetic you use and duration that you use, but typically that's the insurance's guideline. So I'll inject medial branches at lumbar levels 3, 4, and 5 on each side. I'll send the patient home with a pain diary, and then they report back the next day. If I consider it to be positive and have that 8% relief, then we'll do a second one. Insurance companies require that you have 2 of these confirmatory tests before you proceed with a radiofrequency ablation. That's typically performed through needles, very similar to the blocks. The needles are a little bit bigger, 17 gauge versus something like a 22 gauge. And then it just creates a current, heats up the tips of the needles or the tissues at the tips of the needles and burns these nerves. It doesn't incinerate the nerves. I describe it to patients as kind of strips the bark off of the outsides of the nerves and creates some specific tissue changes there, but that eventually regrows. And we report to patients it can provide anywhere from 6 to 18 months of pain relief, but it varies in different patient populations. So, and then there's that stat about lumbar branch RFA and how effective it is if you're treating the right patient population, meaning obviously they have low back pain, but the whole topic of this talk is trying to decide what's causing their low back pain. Is it arthritis, muscle pain, spinal stenosis, et cetera? And so if you have taken the time, properly diagnosed it as stemming from the facet joints due to osteoarthritis, then RFA is a good option. So failed back surgery syndrome, I'm not going to pretend I know too much about lumbar interventional surgery or just surgery to begin with, but this is the definition that a lot of people operate under, which is just a chronic, long-standing low back pain, again, with patients who've had some sort of surgical intervention in that area. What are interventional options for these patients now that they've come back to the pain clinic, or maybe it's their first time in the pain clinic? So spinal cord stimulation or SCS trial and move to permanent using paddles, leads or other, or cylindrical leads, intrathecal pump placements, delivering opioids or local anesthetic or other, like ziconotide or baclofen, but not typically for this indication. And then dorsal root ganglion stimulation, which is a little bit more focal type of neuromodulation. This just talks about surgical revision for FBSS, and I'm not going to talk too much about that, but specifically spinal cord stimulation, it's not necessarily a young technology, but it's something that is improving, I think, each and every year. We should get a Medtronic rip up here and talk a little bit about that, but arguably it does a little bit more than just the initial purported mechanism of action that was, say, 10 years ago, which was just gate theory of pain. So now they think there are other components contributing to this pain relief, arguably effects on the supraspinal components in the central nervous system, or possibly induction of this descending inhibitory pathways coming back down to the low back. So I'm just going to cite a couple studies here. In the upper right was just some current perspectives on failed back surgery syndrome, but also the precise study, which they basically did a large comparison, I believe is an RCT, of patients with SCS, and they understood that these patients still incurred a great cost to society per patient, but that spinal cord stimulation implantation would be cost effective in 80 to 85% of these patients when adjusting for quality adjusted life years. So basically stating again, if you've correctly diagnosed these patients, if they are appropriate, then performing this permanent implantation is a good idea overall. For those of you who don't know, spinal cord stimulation and DRG and peripheral nerve stimulation is usually performed on a 2-stage basis. So it's an implantation of a temporary percutaneous device that's in place for anywhere from 5 to 10 days. And then the patients follow up in clinic. That device is just then simply pulled out, and then we assess the patient in that time duration. We say, how well or not well did this device work for you in this time period? Did it significantly improve your quality of life? Did it significantly enable you to do a different or added functional outcomes. Could you take out the trash more easily? And then we also look at numbers and baseline functional or baseline visual analog scale pain scores. So, and then it's up to the practitioner whether they want to proceed with a permanent implantation or not. So I would say the majority of my trials move to permanent. I'm a little bit more conservative in who I even put a trial in, but oftentimes that's all that I'm left with. So, and then dorsal root ganglion stimulation. So this is something a little bit more focal than spinal cord stimulation. It requires a little bit longer of a procedure, and it targets obviously the dorsal root ganglion, and it takes a little bit more practice. But you can target multiple levels, multiple sides, and be more focal in your distribution of these leads. When compared to spinal cord stimulation, it does have some advantages. It's better for things like causalgia or CRPS, where you're trying to get a little bit more focal in your stimulation. But again, there's a lot of controversy as to in whose hands this should be given, because it is a little bit more complex of a procedure requiring a little bit more practiced and delicate hands. So that's basically stuff I just said. This was just regarding this paper where they compared the two in treatment for CRPS and causalgia at 3 and 6 months. And it basically concluded that there were some small differences in treating pain relief, but that each spinal cord stimulation and DRGS provided significant pain relief for both. So kind of veering off of low back pain a little bit. So. But that's the end of my talk. I had a little bit more specifically just about the cases, but I'm going to get into it. I'll just answer questions if you guys have them.
Thank you. Thank you very much. Yeah, so just a couple questions. Discograms.
Not performed commonly by me. I saw them more when I was younger and in training, like 12 years ago, younger. But not that I can speak intelligently on, and not something I even see frequently nowadays.
And how about radio frequency ablation of the nerve endings to the disc for discogenic back pain?
Again, it's, I think, a burgeoning technology and one that has not yet been sussed out enough that it's something that I want to pursue. But like you said, with some of the other technologies, it's definitely done by people out there, and patients will come to you either wanting it badly or having it already been done and it didn't work, and maybe something worse has happened. So
Right. Perfect. All right. Thank you.
Yeah, no
Appreciate it.
problem.
We'll bring you guys back up.
Excellent.
For case discussions. Yeah, let me give that. Trost. So it's my pleasure to introduce Dr. Trost, who's a wonderful mentor, my boss. And then also has done all of this stuff for a while. That's a backhanded compliment. So he's seen a lot of the treatments for back pain from the surgery side come and go and come and all these kinds of things. So it would be great to hear his viewpoints on these things, and hopefully his talk will load. So I think the nice thing about spinal cord stimulators is you can try them. There's methodologies to do trials as opposed to just implanting them. But certainly the indications have broadened over time. So it used to be really just like radiculopathy or neuropathic pain was the indication for stimulators, and then they started to change the frequency settings for the stim, and that led to some thoughts that maybe it would help with axial pain. And I'm sure there's a lot more to learn as we learn about what happens in the neurologically, the kind of the changes that occur in the entire neurologic system, as opposed to just thinking about, oh, we're just kind of distracting the patient. We're actually might be actually causing a functional change. The question is good because you could talk for like about a week on that. So, okay.
All right.
Thanks, Greg.
So this is a topic that was heresy when I was a resident. So this now goes back to, unfortunately, the 1990s and before. And the resounding answer to the question I pose up here was no, you can't treat surgery with back pain. You saw a patient with back pain. There was no way you were treating them. You were sending them away and not doing anything about it. So the early part of my career was based upon that philosophy. And then I got to believe that treating discogenic low back pain, which we'll talk about, was actually reasonable. And there's actually some evidence that works. And then over the last 10 years, I've become a little more aggressive. I think as I've gained experience and confidence in interpreting films and patients and so forth, that you can treat other entities. And we'll talk about some of those entities also. So I don't have any disclosures related to this, unfortunately, but I've been around long enough that I at least qualify as class 5 evidence. And if you only think I'm half an expert, then it's class 10, but it all works out okay. So as you can see, there's a fairly significant lifetime incidence of low back pain. The problem is we don't speak about low back pain in a reasonable categorizable sense. We all have different names for it. So I'm going to talk about specific entities, 5 that I think you have some impact in, and ways to work them up and maybe ways to treat them. All right. Infusion is not the only answer. Most people have, low back pain that lasts less than a year, but you can still see there's a significant number of patients that have low back pain that don't get better after a year. So this is a survey that was done by, most of the guys are at the Cleveland Clinic. Seth Williams was from here, but these are mostly people that I know. And this is just sort of looking at physicians' attitudes towards treating low back pain. And what they found out, and this is just looking at fusion versus not fusion, is that if you went to a private practice person, you had a higher likelihood of getting an operation or a fusion for back pain than you did if you went to an academic institution. And I'm not sure that means a whole lot. I think if we all have the same understanding of what we're treating, it's better. Okay. So these are the things I'm going to spend a little bit of time on. I won't spend any time on deformity since Than already covered it. But you have to remember that that's the biggest freaking thing that we do. All right. And we say that we can fix your back pain with these giant operations, but yet we're hesitant to operate on people that have these smaller things, this discogenic low back pain, lumbar stenosis, SI joints, facetogenic pain. And these are generally, from a general standpoint, in my mind, usually single level disease other than the lumbar stenosis issue. All right. And I'm only talking about low back pain. I'm not talking about people that have leg pain with it. So this is pure axial back pain. Okay, so we've treated some of these over the time. All right, so we know that back pain has multiple etiologies. It's hard to identify the pain generator, and I'll talk in some of these entities a little bit about how I determine that. Some patients are crazy. But the question is, were they crazy before they had pain, or did the pain make them crazy? And I've operated on people over the year that I thought were just flagrantly nuts. And I operate, they come back to clinic and they're a normal person. And so I'm often confused and spend some time figuring that out. I don't offer low back pain patients surgery the first time I see them. You have to get to know them. Someone once told me that if you make the beast, you live with it. All right. And don't operate on someone you don't want to see in your office every day for the next 5 years. All right, which is why we often say we do spine chiatry clinic. All right. I can summarize the literature as this: the quality is poor, right? It's all sort of class 3 evidence at best. The one thing there's good evidence for is discogenic low back pain, but that was an IDE study for the FDA that looked at infuse in LT cages. So that's one thing that actually has class 1 evidence, although it was just safety and et cetera. Etiology of back pain, you can see there's a million reasons for it. I'm not going to go through all these because there's this presentation stemmed from something I gave at the Interurban a couple of years ago, which was 95 slides. I cut it down to 51 for this, but we're going to eliminate most of those slides. So this is just a nice Venn diagram actually of back pain, where axial back pain and radicular pain kind of overlap, and where each of these syndromes kind of overlaps. You can see they all have some little touch to axial back pain. So we know that our lumbar stenosis patients have back pain, the majority of them. And we always tell them, we're not treating your back pain, we're treating your leg pain. All right. I already told you about nuts. These are more nuts. These are not some of the patients I've treated, although they could be. Discogenic low back pain, controversial topic, right? And I'm not going to spend a lot of time talking about all this stuff, but needless to say, The discogenic back pain patients that I treat are people that have single level disease. It's typically L5S1. They're typically young. You need to eliminate all psychiatric factors. They have to completely have participated in a rehab program. All right. So lost weight, stop smoking, so there's a lot of hoops to jump through before you get to the point of having surgery for it. Okay. I'm not going to talk about etiology, but they often describe this pain as a deep, agonizing midline low back pain. So the stuff that's sitting out here in the paraspinous muscles, that's not the stuff you're looking at. All right. And I already told you all this. Get rid of all the psychiatric crapola. Radiculopathy. You say no radiculopathy, but occasionally these people, because they have disc space collapse at L5S1, they may have some L5 pain, which is sometimes the only way you get them to be operated on and have their insurance pay for it, is to convince them that they have radiculopathy. All right, so it works out pretty well. Blah, blah, blah. We talked about all this already. Ideal patient already talked about. I'm not going to talk about Waddell signs, although they can't have any. So you should look that up, okay? Everybody conservative treatment prior to doing it. And you can see there's a long list of things that you have choices of. And I'm going to show you kind of an ideal patient. All right. So this is a patient that came with this deep agonizing low back pain. They have problem is they have a little degeneration at the disc space at L4-5. And then they have this disc space at L5S1 that's collapsed, all right, which is one of my bigger criteria. They have modic end plate changes, typically modic type 1, not modic 2s, okay? So they shouldn't have fatty replacement in their end plates. It's ideally just edematous changes, all right? So that's one of the things they do. This patient just had a discogram, and just to comment on discographies, I don't use it often at all, and I use it more to eliminate patients, right? So if I inject a disc that looks normal and they have pain, there's no way I'm operating on them. And I'm not so concerned that the disc space that I inject is positive. So if we do this L5S1 space, it's probably going to leak the dye anyway. So I'm not so concerned that that one is positive, but that the other spaces are negative. And if that's what happens, then they end up with an operation that I think works pretty well, which is just an anterior lumbar interbody fusion with a cage. I don't do posteriors with this. I've never done it in 20 some odd years of doing this. Tom Zadeblik, the ortho guy that just retired, that did a ton of these, did hundreds of these. And I only remember one case that he had to add posterior instrumentation to. So it works, it's pretty well. And it fuses because and BMP fuses essentially, the literature says 98.5%, it's virtually 100%. I've never seen a non-union with this particular device. All right, facet disease. We've already talked about the signs and symptoms of facet disease. This is one of those things that's hard to sort out because patients often come to you with multi-level facet disease, and to try to figure out which facet is causing problems is often difficult. So this once again gets to be people that have primarily for me, single level facet problems, not multi-level. They tend to be pretty young. And this is another set of patients whose symptoms seem to be out of proportion to how bad their radiographs look. They often have no lumbar stenosis, nothing. They just have a set of facets that looks bad, and often have facet joint effusions. My workup for these patients is I actually do bilateral facet injections at the level I think is bad. And they have a positive, if they get better with it, I wait for their pain to come back and then I inject it a second time. And if it gets better a second time and then comes back, then I feel comfortable that offering them surgery is not unreasonable. And I have about 5 of these patients now since it's a recent thing, and it's so hard to find someone with single level facet disease, but they've gotten better. And it's gratifying to see them get better. And it's just a standard posterolateral lumbar fusion. You can do interbody if you want, but that's what I tend to do with them. So I'm going to show you one lady that I did. So there's all these other things to do. But this is a 34-year-old lady with back pain only for 7 years. She'd been through a ton of workup, and it had facet rhizotomies and everything. These are her facet joints early on in this thing. They don't look bad at all, right? She comes to me after having literally this whole laundry list of stuff done. All right, so radiograph after radiograph, some of it not for her lumbar disease, but you can see there's tons of lumbar stuff in there. So she came back with these facets, and you can see that they're a little bit overgrown now. There's a little facet joint effusion and stuff. So I did the bilateral injections on her a couple times and then fused her, and she did miraculously well with it. And I thought she was crazy. So once again, it's one of these people you see in clinic over and over and over again until you're convinced that you can probably help them. Okay. The other major entity that I'm going to talk about is claudicat and low back pain, which is low back pain with spinal stenosis, but no lower limb symptoms. All right. And these are the people that have back pain. When they walk, their back starts to hurt. They maybe get better by leaning over, but it's the same thing you think about with neurogenic claudication, is that instead of just having leg pain, they get back pain with it. And I didn't believe in this until, Tom Zadeblik talked to me and said, listen, what's the first sign of first symptom of low back or of some spinal stenosis in most people? And they tell you it's low back pain. And when you operate on people with neurogenic claudication that have back pain and leg pain, their back pain tends to get a lot better too. The workup for this is essentially the same as with the facet injections. And I do a lumbar epidural steroid injection at the level that I think is bad, or the 2 levels that are bad. I do a transforaminal injection, pick your side, right or left, it doesn't really matter. If they have a significant response to it, then I say, okay, we'll wait for your pain to come back and then re-inject you and see if you get better. And if they do, then I'll operate on you. This is another one of those things where you have to be careful about how you talk to patients about their response to their injection. I'm not looking for 3 or 4 weeks of response. I say, were you better, overnight or for a day or two? Not because they always say, I came back, no, I'm not very good. It didn't help me much. And then you got to pin them down. Was it a couple hours, a day, overnight? Anything that you notice was better. And a lot of them will say, yeah, I was better overnight, but then had no long-term relief. Well, that's not really what I was after. I wasn't after long-term relief because I want to operate on you. But they get it. And once again, only about 4 or 5 patients in this whole series now that I've done, but they've had response to it. And I've worked up several people for it. I've got 2 people right now kind of in the hopper. And this is a guy, that has lumbar stenosis. And has low back pain only, no radicular pain, no signs or symptoms in his legs at all, and ended up with just an L4-5 decompression, and did well with it. And I mean really well with it. I'm not looking for just a little bit of relief. I'm looking for my back pain is substantially better. It allows me to get back to what I was doing before, and I'm happy I had an operation. And you have to also remember, though, that placebo effect is about 40%. For anything we do. So there's nothing solid that I can say about any of these sort of fringe entities, other than I think it works. SI joint, I'm not going to say much about. Okay. There's a bunch of people that talk about fusing SI joints. I think it actually has a place in treating patients, but I think the place that it's probably going to be most effective is in people that have long segment lumbar fusions or lumbosacral iliac fusions that have iliac wing screws and not screws across the sacroiliac joint. I think those people may benefit from a fusion of their SI joint in combination with it. The tests for SI joints are inexact and non-scientific, and so people say, yeah, I do these tests, they have 3 out of 5 positive, and then I fuse them. Well, the tests aren't very good anyway, and the results from the surgery aren't good anyway. And I know guys that have done hundreds of these things, and Dr. Brooks is actually going to be doing a debate on this in Cleveland this year, and he's the pro, so we'll have to see. I gave someone else the con because nothing's more fun than being a one-legged man in an ass-kicking contest. So I gave that to Than. So I appreciate your attention. This is my grandson, whose 7th birthday is today. So I have to go have dinner with him now. So I'm happy to take any questions. I think Than has cases, and this is his new dog. So
yeah,
they're buddies.
you can see a guy who's about to retire.
Well, at least I'm old enough, I'm old enough
Developing
to
other
have
interests.
grandchildren.
Get Allison and Kath, if he's still here. Thank you very much.
Thanks.
We're gonna do a real easy case. So we got a 40-year-old woman with low back pain and sciatica, okay? And this is her imaging. Sciatica, what, anybody know what that means? Not you guys. Anybody else?
Unprecisely defined term.
Yeah, okay, so not unlike lumbago, which is another diagnostic term that we use, which is the low back pain, but it basically is like a grab bag of any possible things that cause pain in the back, and then they lump sciatica into that. So when you're coding, they'll have back pain, they'll ask you which side, then they'll ask you if there's sciatica also. Sciatica is radiating leg pain, but of course it's a grab bag, right? So if you have like a hip problem, you could still think you have sciatica. If you have typical sciatica, myofascial type pain, you could have sciatica. You guys saw all of the like referral patterns of all the different joints, right? It's and those kind of overlap with dermatomes, so it's very confusing, but that's sciatica. So the way I define it is basically anything that's not radiculopathy. Okay, so non-dermatomal distribution, but that it's still not a good definition. Okay, so let's start with Allison on this case. Is just like, this is the imaging, which is, I'm going to say the only thing really of finding on here is a relatively young person with a disc at L4-5 that doesn't look totally normal. And then it has a blue, tiny blue arrow that the radiologist said was an annular tear, which also probably doesn't mean anything. Okay, go ahead.
It does.
So yeah, I mean, if that's that sort of high intensity zone is
Yeah.
corresponding to her pain, we could think about that as one of the potential causes of the axial low back pain. But I think when we talk about that radiating leg pain, we really have to think about, really for the low back pain and for the leg pain, what are all of the different causes? We talked a couple times about the facet referral patterns. There's referral patterns for the SI joints that can go down into the hip, the groin, and down the back of the leg. And then we also, the structures within the SI joint and piriformis muscle and sciatic nerve. So those can actually cause radiating leg pain in certain patients. So thinking about like what are the spinal versus extraspinal causes of these types of symptoms.
So kind of how do you approach the patient, like just from your like the history questions that you're asking, and then also just like some of the exam things you might do to try and differentiate between myofascial SI and axial back pain?
I think the myofascial diagnosis tends to come towards the end. I mean, we can, it's more of a clinical diagnosis where we actually palpate like trigger points in the lumbar paraspinal, gluteal muscle, that sort of thing. But I do SI joint maneuvers and will still use the 3 out of 5. If I'm able to provoke a number of, usually I use thigh thrust is more sensitive than some of the other maneuvers. And really getting a good idea of like where it seems as though, I think Dr. Sewer said, just having the patient point to where that center of like where their symptoms are most painful. And then one of the things that I do, not that this is really advanced, but it's just, what within that physical exam is reproducing your typical pain symptoms, like the symptoms that you came in to see me for. Because a lot of things we can do within the physical exam can provoke pain. But is that your typical pain? Is that the pain that really brought you to this visit today?
Do you have any questions? I say this kind of as a loaded question because I do, but questions that you ask about their social situation, their psychological situation, anything like that to help piece all this together?
Yeah, absolutely. I mean, I always ask about sleep and sort of pre-morbid psychiatric history. And I always sort of couch it as like, when patients come in with chronic pain that affects your quality of life, in someone who never had depression or anxiety before, that could cause and manifest those symptoms. So that's why it's important, to me to hear about like how this is affecting their mood and their ability to function. And then, getting a little bit of that history too, like did they have depression or PTSD? I mean, we know adverse childhood events, trauma, all of these things are very much associated with chronic pain states.
Yeah, so the kinds of questions I'll ask especially is like, when did the pain start, and were there big changes in your life when the pain started? So things like in a 40-year-old divorce proceedings or something like that, where they kind of seem to correlate. And so I'll kind of watch for those kinds of associations, especially in images like this, because it's like there's nothing emergent about doing surgery on them. So I have a little time to get to know the patient, kind of thing. Just as an example. Kath, thank you, by the way. Kath, thoughts about trying to work this up more in other interventions besides what we do?
Yeah, I think kind of what you're trying to pull out of Allison, I would say that it's very important for me to just say, where's your pain? Is it, is this true sciatica? When I hear the word sciatica, I define it as you do, but it's also to me much more of a layman's term, just because it's what the patient says to me. It's like my sciatica is acting up.
Yeah, I don't really think it's a medical term at all.
Right. Yeah. So, which is funny because I've heard nobody in my life ever say lumbago. I don't.
I know. Exactly,
not
right.
like in conversational use anyway.
We're gonna
in
get
any
that
case,
started, though.
if this is them saying that, then I need to know what they mean by it, right? Is this a piriformis syndrome? Does it start in your buttocks? Does it go down your leg? What dermatome is it mirroring? And then and then they say my leg. I'm like, is your hand, does this go down the side of your leg? Does this go down the back of your leg? Which dermatome is this consistent with? Is this not true, radiculopathy, or is it, is
Yeah,
it
this
just
is not meant to be a quote from the patient, but
I mean,
it's a good point. Yeah.
But the annulus can give you leg pain too, just like anything else.
Exactly. Yeah.
And I would say that 20 years ago, there was a treatment for this. Actually, people would do discograms on them, and people, that had these annular tears would have a high correlation with their discography. Some people would do anesthetic discography, and then we would do these intradiscal electrothermal annuloplasty, basically. And it actually worked. I think I did 14 or 15 of them. I got stuck doing all the needle stuff here early in practice because no one else wanted to try it. But once again, it's a company that went out of business. But I think about 80% of people had basically relief of their back pain with us. Once again, single level disease. They'd been through all the conservative stuff. But right now, I wouldn't proceed with any other diagnostic test because there's nothing I can do about it.
So that's for the residents. When you're looking at an old textbook, that's the IDET procedure.
IDET, that's what I was thinking of.
Yeah, but I did.
What's the acronym?
Yeah, I did worked. And, once again, a lot of this stuff is just about really good patient selection for surgery, at least.
So you think annular tears mean something? I always tell patients they're just there.
No, it's actually a high correlation with discography for these things. So if you do a discogram on this patient, they'll have pain at that level. 80% of the time.
I think the problem was the studies for discography were not probably done that well. So they then basically didn't see a good correlation between discography and patient outcomes.
Yeah. Right, because it's, once again, an inexact test, looking at an inexact diagnosis and then coming up with procedure and then back extrapolating the procedure work, then the discography meant something.
Yeah.
So we do that a lot.
So I think these are some of my toughest patients. They typically will come back many times to my clinic. And then I try to cycle them through other non-surgical treatment options and things like that. But I think
I would just say, not to cut you off,
Yeah.
but these patients are getting an epidural in many private
That's right.
practice institutions. I mean, whether and academic institutions, just because it's relatively non-invasive.
Yeah.
And
do you think that is a reasonable treatment option, or you're just saying that's what they end up getting treated as? Yeah.
both, depending on what the rest of their HPI reveals, because I mean, if we think, is it a radiculopathy, or are there other testing? Do they get EMG, things like that? Also, I think it's important to help suss out with these patients, like how long has this pain been present, this sciatica and lumbago? If they say a month or 2 months or whatever, and I say, okay, so prior to 3 months ago, did you have back pain, right? Or did this all just start and is it all connected and things like that?
Right,
So
right.
need more information, yeah.
And other treatment options, exercise, things like that you guys recommend or
I think they get the same old with usual physical therapy.
let's get, I mean, we, on our side, we just think like, okay, we just have to do something to them for 6 months and then the insurance company will, but maybe there's more to it. More.
Well, I think, within the pain clinic, there is that multimodal plan of care for taking care of patients with like, whether or not it's coming from the disc here or it's more myofascial pain and really working with I think their work with the physical therapist and really that can be helpful in teasing out where the primary pain generators are as well. And then getting engaged with other modalities like acupuncture, osteopathic manual therapy, whatever is there. I mean, I think that whatever is there that the patient will really truly engage in. So.
Yeah, I mean, I feel like I have the patients kind of do as many things as I think are reasonable to determine this is, that they're going to be on the same team with me when it comes to time for surgery. Basically, like they're cognitively capable of kind of working with the program, basically.
There's not surgery for this.
What's that?
There's not surgery for this.
For this?
Yeah.
You say you wouldn't do surgery for that?
Nope.
Yeah.
I think I'd have to see disc space height, stuff like that. Yeah, I don't, the annular tear in and of itself doesn't drive me towards surgery because I don't think I would have an effective treatment for that. Lumbar arthroplasty is probably only done at the Texas Back Institute. There's a whole bunch of other issues with it. So I'd probably have to put it in the category of discogenic low back pain and make sure that I believe that that was a diagnosis rather than the annular tear.
And is that where where you've used the discogram in the past? I mean,
For
discogenic low back pain?
I use the discogram to eliminate patients from having surgery rather than to say they need surgery. Or if there was some question in my mind about, is this patient really a straight shooter, to help sort it out. I haven't done a discogram now in probably 10 years.
I don't know that there's anybody that does them.
No, you can still get them.
Yeah.
Yeah, but I, it's like everything else though.
Probably some interventional pain physicians who did them accidentally trying to gain.
Yes, well, of course, I mean, that's the other part, but the
RFR inside the disc space.
So I think just for the sake of time, we'll stop here, but I really appreciate you guys taking the time to talk about this very difficult problem. Any other questions from the rest of the team? So thank you, everybody. We have lab tomorrow, starts at 8 a.m. There will be food, breakfast and lunch and coffee and all that good stuff, but obviously, when you're working on cadavers, you don't eat, drink, and do cadavers at the same time. So you show up a little early. We only have 3 cadavers, so just be mindful that we're trying to prioritize the people that really need to get their hands on things, and we'll go from there. But certainly, there's opportunity for everybody to learn. So thanks everybody for your participation this afternoon. Really appreciate it. Oh, and thanks to Chad for sticking it out with us.